Karthi, Karthi, Karthik, Karthi.
You can probably leave a message because sir might go online.
Okay.
We are already online. We are already live. I'm letting all the participants in. In a minute, you can start once all the participants are inside.
Yes, sir. Mentors and moderators, for some time, please mute your audios. Good evening, everyone. Welcome to the 11th session and the final session of Ask Your Mentor. Today, on behalf of our host, Dr. Tumescent sir, our president, Dr. Reena ma'am, and myself, I welcome the mentors and the moderator for the last session, which is the miscellaneous session. Along with this, you also have your malignancy session, which was missed in between. The mentor for the malignancy session is Dr. Ilangumaran. For the miscellaneous session, we have Professor Dr. Ashok Ramadure and Dr. Thomas Zakaria. The moderator for both the sessions is Dr. Karthik. I request all the participants to mute your audios and videos for a smooth running of the session. We will begin with the malignancy session, followed by the miscellaneous session. The mentor, Dr. Ilangumaran, is Associate Professor, Department of Oral and Maxillofacial Surgery, Sri Ramachandra Institute of Higher Education and Research. He completed his MDS from Sri Ramachandra University, Chennai, and went on to pursue his fellowship in oral oncology at Kidwai Memorial Institute of Oncology, Bangalore, 2010-2012. He has also done his fellowship in head and neck surgery from International Federation of Head and Neck Oncological Societies. Dr. Ilangumaran does exclusive practice of oral oncology and maxillofacial procedures. He has handled more than 1,000 oral oncology surgeries and is no doubt an apt mentor for today's session on malignancies. Welcome you, Dr. Ilangumaran.
Yes, ma'am.
The moderator for all the sessions, Dr. Karthik Ramakrishnan, has completed his BDS in 2004 and MDS in 2007 from Annamalai University. He was awarded the best outgoing student for securing highest mark in his final MDS examinations. He has several national and international publications and has delivered many guest lectures at state and national conferences. He is currently pursuing his PhD in ophthalmic complications and orbital trauma. He has also designed a digital ophthalmometer and awaiting patency. He's in active surgical practice for 13 years, performed more than 3,500 various surgeries, currently working as an associate professor at SRM Katangulathur Dental College. Welcome, Dr. Karthik. So we'll start with the first session and over to Dr. Karthik and Dr. Ilangumaran.
Good evening all. Thank you, Tumescent sir, Madhu madam, and Karthik. Shall we start? Karthik, is the screen visible?
Karthik, you have to unmute yourself.
Karthik. Karthik. Karthik.
Oh, yeah.
Karthik, shall we move on? Professor Karthik. Okay. Tumescent sir, I am audible, sir?
Yeah, you are audible. You are audible.
Okay, sir. The screen is seen,
Karthik
sir.
is not able to hear us.
Dr. Ilangumaran, can you just move the slide to the next one? Maybe
Sure,
I can start the question.
Yes, ma'am. So,
okay, the first question that is asked is the importance of tumor markers.
Yeah. So, oral cancer or any other cancer, the tumor marker plays a vital role. But for oral cavity, if you look into the articles, there are so many articles are there, but we don't prefer doing a tumor marker. The reason is it's all quite visible, because when the patient comes to you, you can ask the patient to open the mouth and you can clearly see where the tumor is. Once when you see the tumor, you can go ahead with a biopsy and you can diagnose the tumor. So that is the gold standard. There is no doubt about it. You should not have any doubt in that. But in case if a patient comes to with a breast cancer or cervical cancer or lung cancer, for example, if you take lung cancer, you can't do a direct biopsy in the lung because the patient may end up in pulmonary dysfunction or any other comorbid, morbidity associated with the biopsy procedure. So in that situation, you can rely on tumor markers or biopsy of regional lymph nodes. But oral cancer per se, there is the tumor markers is upcoming, but there is no clear-cut tumor for the diagnosis. The gold standard for diagnosing oral cancer is your biopsy. When you do a biopsy, you are very well clear in the microscope what is the type of the cell, and you can treat the patient accordingly. But interestingly, this is an article I found out where there are markers are there. If for basics, if you want to know what is tumor markers, to put it simple, it is a liquid biopsy. You take the example of blood or saliva or any other bodily parts from the patient and test it in a laboratory to check for any abnormalities. That is the tumor markers, which recent days it's been called as liquid biopsy also. But there is no clear cut. The gold standard here is the biopsy, but there are few studies which demonstrate that in post-operative session, the patient might develop a recurrence. In all those things, there are few listed articles here where they have done markers. You can go through it, and it is a place for the research. And you can, in future, you can go into research in tumor markers in oral cancer.
I
That's
think
up,
the
ma'am.
main role of tumor markers would be before, rather
Yes,
than
ma'am.
after the cancer has started. It's mainly the prevention area where the tumor markers should be playing a role.
Yes,
Like
madam.
if
Yes,
you
madam.
see a cancer in a family, you may be prone to cancer. So in those patients, the tumor biomarkers, if we have and we can identify, I think it will make more sense rather than
Yes, ma'am.
after having a frank carcinoma and going in for a tumor marker test. I think
Ma'am, and also in Kerala, they've conducted a study, madam. I think Moni Kuriako's its team, they have done a study where in the periphery of Kerala, in outreach area, they've collected the samples of saliva and they have taken few cells, malignant cells, and they worked on it. And there are few studies, there are n number of studies are there, but the
exactly
gold
because
standard here, I
apparently
wanted
my
to.
PhD was on one of the cancer
Okay, ma'am.
signaling pathways. So I really
Ma'am,
understand that
you
there are a
yes,
lot of
ma'am.
it.
Ma'am, you can throw some light on the topic, ma'am.
No, that's what exactly. The tumor markers, if you look at it, is too many to mention.
Yes,
Obviously, the
yes,
proven one is our P53 one.
yes,
But
ma'am.
apart from that, there are lots of and there are lots of pathways also in it. So
Yes, ma'am.
the question is endless and it's more a research oriented. But as clinicians,
Yes.
what we look at it will be the pre-malignant conditions and picking it up as early as we can. I
Yes,
think
yes,
that's what it is.
yes, ma'am.
We'll move on to the next question.
Oh, yes, ma'am. So, Karthik, you want
Me
to
to
read the
move the
question?
slide. No, I can. You can move the slide. So, the role of
Ma'am,
tobacco in pathogenesis of oral cancer. Which form of tobacco is the most uh, common for causing cancer in our population?
ma'am, everyone know that oral cancer is caused by tobacco. So, what
Right.
exact answer will fit in this question, ma'am?
Now, the thing is, mostly if we look at the Western population, it's the smoked form of tobacco. And
Yes,
in
ma'am.
our population is more of the smokeless tobacco. So I think that's the question because in the smoking
Okay, ma'am.
form, they say the reason is the presence of nicotine and nicotine related factors.
Okay,
So
ma'am.
in your chewing tobacco, what are the factors and how does it play a role in pathogenesis? I
Okay,
think
ma'am.
that's the question.
Okay, ma'am. So, being a surgeon or in the healthcare, being a dentist, what you are supposed to know, the most common etiological factor for oral cancer is there are two forms. One is the smoking form, and next is the smokeless form. In India, if you take the lower socioeconomic status patient, they think the smokeless tobacco is more predominant in the population. The reason is they say when they take the tobacco and put it in the vestibule, they say that creates that doesn't stimulate your appetite, so they can work for a long time without taking the food. So in that way, eventually what happens when they don't take the nutritious food, their host mechanism goes down, and which in turn forms the carcinogenesis. It's been initiated. Coming to the cigarette is not directly been the causative agent for. It is one of the most common cause for oral cancer. But here, if you take the cigarette smoking, the most common area is your commissure. The reason is because the smoke is getting concentrated more in the commissure, because when a person takes the smoke and put it in the orbicularis oris, the more concentration goes to the commissural part. So
Okay.
one area, if the patient is a smoker, he might have a commissural cancer, or next he might have a tongue cancer. These are the two things. Here the
Okay.
alcohol is a synergy. When you mix alcohol with both this form of tobacco, either the smokeless form or the smoking form, what it
Okay.
does is it activates the pathway of carcinogenesis directly into the our homeostasis, and this is the one factor which is the one which causes cancer.
Okay.
Anything else you want to add on this topic, ma'am, since you are doing your
No,
PhD?
I think you're pretty okay with it. We'll go on to the next one. Thank you.
What is
So
the
coming,
Yes, Ashok sir.
risk? What is the risk factor for somebody who abuses both smoking and alcohol? Say, for example, pan and alcohol.
that's what it is like a
No, in
synergetic
percentage
factor.
wise, like
No, smoking, you're
200%.
saying so smokeless and alcohol. Smokeless tobacco. Pan mane, you're saying the smokeless form of tobacco.
Yeah, I mean, anything, smoking, smokeless
In
with
both the
alcohol.
forms, sir, both the
Yeah, I'm
forms.
talking objectively. I mean, what do we tell our trainees if you have a patient who
They can
abuses
either use
alcohol?
use one or
Huh?
I think only
the-
alcohol, actually, they say it doesn't have more prediction
yes,
for
yes,
causing oral cancer, right,
yes,
sir?
madam,
Only
yes,
if it's
madam.
with tobacco and added form, as he said, the absorption or some mechanism
Is more.
works better to cause cancer.
Yes,
No, certainly
Ashok
there
sir?
is an increase. My question is it been
yeah,
published? Like
very much, sir.
when
It
we
is published and
were
it has
said like
been
two and a
it
half times more or something like that. So I just wanted
it's
to
been
confirm.
published. It is given in Sterling Maran, sir. All this endless, I mean, all
So he's
the
asking the
forms of
prevalence and the
tobacco.
incidence by percentage, I think Ashok sir is asking.
Percentage, I'm not sure, sir. I'm not sure about it.
They say about two and a half times more risk or something like that. I can
Okay,
remember.
okay, okay, okay.
So with
We'll go on
next
to the next
question,
question,
sir.
ma'am. Yes, ma'am. So, ma'am, genetics in malignancy.
You need to change the
So,
slide,
you,
doc.
ma'am, is it okay?
No, the slide hasn't changed.
This one, ma'am.
No, slide. Yes, genetics and malignancy.
It's seen, ma'am.
Yeah, it is changed. It is changed.
Now it
You can
changed. The
see.
previous one. The previous one.
Yeah, yeah.
Ma'am,
I think that.
the question is about the basics of genetics, ma'am. Is it so?
Yes, the question is, can you hear me, Dr. Ilangubaran?
Yes, yes, Professor Karthik.
Yes. What is the role of genetics in malignancy?
You need the basics, isn't it?
Yes.
Basics.
Is there
So
a role
to
of genetics in
understand,
malignancy? How prone
thank
are
you.
you in a genetic way?
Sure, Karthik, sure, Karthik. So to understand the concept behind this malignancy or the genetics, we should know about the genes. So I thought of taking Rajinikanth for help in this question. So every one of us would have seen this movie Indian, isn't it? Here there are three characters revolving. One is the good professor, where what's his name, Karthik? Rajinikanth, the good Rajinikanth, and the robo Rajinikanth is a Chitti, and you have the Aishwarya Rai. These are the three people we have here. So here, in also in malignancy regarding to genetics, we have three cells. One is the tumor suppressor gene, which means when the tumor comes inside the body, our body mechanism will suppress it. That is the Professor Vasikiran, the good Rajinikanth. And we have the bad robo, the Chitti, which is your oncogene, which will by form of and tobacco with alcohol, this oncogene which is there in the body, which will try to build up and try to give a cancer to our body. That is the oncogene. Stability gene is the one which will balance in homeostasis, where it will maintain the tumor suppressor gene and the oncogene in homeostasis. But what happens when a person abuses the smoke and alcohol? There is enhancement in the oncogene. So the Chitti robo, which goes in for multiple replication. So that is the form where we are getting in. That is what happens in cancer. So the tumor suppressor gene goes down and the oncogene, the Chitti, goes up, and that is the main fundamental basis of a person developing cancer. If you want to know understand the genetics, this is the basic. Tumor suppressor gene, you can't ignore it, and your oncogene and the stability genes. And coming to this, you have to add something called as hallmark of cancer. There are 6 types of hallmarks there. When the cancer comes inside the body, there will be evasion of apoptosis. The normal cell will not die. I mean, it will not die, it will prolong to continue. And you will get vasculature, so the tumor will grow up. So these are the hallmarks, along with the instability in the cancer genome, is the main reason for development of cancer. So this may be an essay question, maybe a viva question, or the basic understanding. In your life, you should not forget Endrian movie and the tumor suppressor gene, the onco gene, and the stability gene, your Aishwarya Rai. Ma'am, is that okay, ma'am?
Yeah, it's okay. Doc, apparently, Jimson sir's made a comment that hope students don't write this example. Students, it's for better understanding. Let not the
Yeah.
answer papers have the characters mentioned.
Yes, it's just for your understanding. That's all.
I was thinking Aishwarya was either tobacco or alcohol. I think I misunderstood.
Okay. We'll move on to the next question, ma'am.
Yes, yes, please.
I think Dr. Karthik is moderating for you now.
Yes.
Yes, yes.
Karthik,
Can you just change the slide?
current
Yes, Dr.
concept.
Kumaran. Yes.
Yeah. It's in Karthik.
What is the current concepts of carcinogenesis?
Yes, this is very interesting because in 2016 I went to MSKCC in USA with Jatin Shah. I was there for a month for this international fellowship. So that time I was seeing a few patients in his OPD. So we are discussing. At that time, I think one, I don't know, forgot his name. One Sinistar has come. He has got C of oropharynx, and he was telling me after seeing that patient. And initially in 1980s and 1990s, people used to smoke and that is the way of life, and they started smoking, and that is the main etiologic factor for patients getting cancer in those times. But in 2020, in the later stage, they have given a lot of advertisements on the cigarette packs, and the people who are smoking, there is a decrease in the number of people who smoke. But still, when they go back and see the incidence of carcinogenesis, it was very high. And the reason for that in Western world is the main cause is the human papilloma virus. The human papilloma virus is the reason for increased number of oropharyngeal cancer, and there are few studies which state that, or I mean HPV, which might also cause oral tongue cancer. And the etiologic factors for human papilloma virus is your multiple sex partners. And there is a study, I forgot the name of the study. In that, they say that a person in a normal average adult, somewhere between 20 years to 40 years, you will have a sexual partners range from 10 to 12, or somewhere between 18 to 14 people. So you'll have multiple sex partners. So the HPV will eventually come into his body, and it will be very salient. It will not do anything. Like our coronavirus, when it enters our normal body, it will not do any person with it will go out with, sorry, let me not introduce that topic. So this HPV will come inside the body, and it will not do anything to the host. And the person with 40 years, 50 years will be living with the human papilloma virus. And when he reaches 45 or 50, or when there is some decline in his immunity, what will happen? This human papilloma virus will progress into cancer. And this is the current concept of a patient getting cancer. And if a person comes to you with an early age of 35 to 40 years with a no history of alcohol abuse or tobacco, then you should think of human papilloma virus as an etiologic factor for carcinogenesis. No worries. If the patient has got human papilloma virus, then the prognosis of the treatment is much better when it is compared with squamous cell carcinoma. So this is about the current concepts on carcinogenesis, ma'am. Is that okay?
Thank you, Dr. Kumaran. By any chance, can it be detected from a patient?
No, Karthik. You can't detect HPV directly, but a patient comes to you with a cancer, then you have to do a biopsy. Once the biopsy has been done, you can send it across to the pathologist. They will do a study called as E16 and E6, E7 protein. It's an immunochemistry study. By doing that, they will come to know whether the patient is carcinogenesis. Their HPV, their cancer is related to HPV or not. And in our institute, we do it for all the tongue cancer. We do this.
Thank you, Dr. Kumaran. Moving on to the next question.
Shall we go to the next question, please? Yeah. So is elective? Yeah, Karthik, go ahead.
Yeah, the next question is elective neck dissection needed in squamous cell carcinoma of the maxilla, in particular of the hot palate?
Okay.
Would you like to answer that?
Yes, yes. So the neck dissection is needed or not for maxilla? That is a question, right? So let's assume that when I was doing in 2010 this oncology program in our institute in Kidwai, we never operate on neck dissection for a maxillary tumor. But as the days progress, uh, we thought that we have to go back and do the neck dissection. I want to tell a secret to the youngsters. The reason is a person known to us who is coming to you for a surgery of squamous cell carcinoma of hot palate, an young person. So you're doing a surgery, primary oral cavity resection. Anyway, you're going to do it in general anesthesia. And to do a neck dissection, it will take another 15 to 20 minutes. By a simple skin crease incision, you can very well go inside and do your neck dissection. The problem in wait and watch is if you on the setting itself, if you go and do the neck dissection, the survival of the patient is somewhere around 90%. But during when you wait and watch, in our India, the problem is the patient never come for follow-up. Initially, for first 3 months they used to come, or next 6 months they used to come. After 1 year, they will go away. They say they are not anymore a cancer patient. They will run freely. They'll come back to you only when they have a tumor or a node in their neck. When a person has got a node in the neck, then their survival decreases somewhere around 40 to 50% drastically. So we want to keep the main idea of any oncologic surgery is to what? To increase the life expectancy of the patient. We want to add years to the patient's life, isn't it? So that is the concept. So if you want to do an surgery for an odd palate, when it is proven to be squamous cell carcinoma, there is no second thought. Just go the neck, go open the neck, and do a level 3 clearance from 1 to 3, or if you are very expert, then go do a level 1 to 4 clearance. So, and the patient will get a very good prognosis. That is the concept behind this neck dissection. Any doubts in this, Karthik, you want to? And this is the article I have taken it, and he
Yeah,
says
good.
that they had a policy of both wait and watch, and they have done a primary surgery. I think it's a retrospective study. They have done only the primary section, and they went back and saw there are patients who have reported to their OPD with neck nodes. And once they have reported with the neck nodes, when it is N0, you can do selective neck dissection. When it is N plus, you have to do MRND. When you do MRND, the complexity of the surgery is more. So the morbidity also increases, the quality of life decreases, and the outcome of the surgery also comes down. The patient will have a lesser life. So weighing both the plus and minus, it is always better to do it when the patient is N0. Go ahead and finish off the neck dissection. It will take another 15 minutes.
Yes, thank you, Dr. Kumaran. By any chance, is it anyway related to the size of the tumor? By any chance, can it be yes for a small, no, yes for a larger size and no for a small size, something like that?
So that's what, if the patient is known to you and if it is a very small T1, there is other article also which they say for T1, T2 tumors, there is no need for neck dissection. But the problem is, what if the patient comes back to you with a neck recurrence? So we have to
Okay.
place a sorry cut. Sorry.
So
Sir.
it is strong yes for
But
the question now.
if you
So
think,
let us move on to the next question.
yeah,
Yeah, sure. Yeah, proceed, please proceed.
yeah, Karthik, if you think that the patient has got a good follow-up, but still, then you can wait and watch. But there's always the take-home message is better go and do it in a single stage. Okay, Karthik, shall we go to the
Thank
next
you, Dr.
question?
Kumaran.
Kumaran, I just have a
And
small
Yes,
doubt to ask you.
yes, sir.
At the interest of the postgraduates. I mean, I
Yes,
asked
sir.
the same question to Jatin Shah in Bangalore. I got up and asked him.
Okay, sir.
See, in the last 2 decades or 3 decades,
Yes, sir.
my understanding is the quality of life
Yes, sir.
because of microvascular reconstruction, etc., has phenomenally improved. And IMRT, everything, the quality has improved.
Yes,
What
sir.
is happening to the survival rate? Say, we will take a typical GBS cancer, gingival cell carcinoma with a positive node.
Yes,
What
sir.
is your statistics of 5-year survival today? And what was it 20 years back or 10 years back?
So according to the literature, if you take any good cancer with a good clearance and based on the nodal status, for example, N0 GB cell plus tumor, you're doing a marginal mandibulectomy and a selective neck dissection, the survival is definitely around 5 years. But being a surgeon, we only treat on the microscopic disease. We are not sure of the microscopic part of the cancer biology. So I have seen a promised a patient with T2 tumor that you live for 5 years, but they have gone down in 2 years. I have told a patient with an advanced malignancy, they are living for more than 5 years. So it is totally depends upon the tumor biology. Coming to the literature per se, if you have a very good clearance and neck dissection, definitely the 5 year survival is there, sir.
Does the role of
I will
field
rephrase this question.
carcinogenesis have a role in this, Ashok sir?
Sorry?
Field carcinogenesis, does that have a role in this, sir? Because I remember reading somewhere by Slaughter et al. That even if you remove the malignancy in that particular area, 7 centimeter margin of the lesion has a tendency to have malignant cells. I mean, this was a very long back reading. So what's your input on that, sir?
You're asking me?
Because, yeah, or Kumaran, sir, because we don't actually go and cut
Yes,
so
ma'am.
much.
Yes, ma'am. Yes, ma'am. Ma'am, I think this slaughter hypothesis is a good question for the PGs because it may be a viva question or a short note. Slaughter hypothesis or field carcinogenesis is important. The concept of slaughter hypothesis is a person smokes. The smoke, it starts from the vermilion of the lip, it goes to the buccal mucosa, your retromolar region, goes to your oropharynx, come to the larynx, and then goes down to your upper respiratory tract, your entire lungs. So he says when a person smokes, the smoke goes from all these areas, but the patient gets cancer in only one place. So the remaining areas that remains that he might get a few cancer somewhere in the near future. That's why we are always advised a patient for radiotherapy post surgery. So in spite of radiotherapy, there are few patients they come to us with recurrence. The concept behind this recurrence is the hypothesis created by our Slaughter, which is the field carcinogenesis or Slaughter's hypothesis.
Dr.
This is
Ilangumaran,
okay,
I
ma'am.
will just
Yes, ma'am.
rephrase my question.
Yes.
My, as I said, we all understand that the quality of life has tremendously improved. I
Yes,
want
sir.
your opinion whether the 5 year survival rate, what was it, say, in the 90s or late 80s compared to 2020, has it improved or is it still comparable? Is it still similar?
It is still debatable, sir. That's what I told, because that we are not sure of the cancer biology, because there are so many factors which depends on the survival. Because if you take the tumor, squamous cell carcinoma, grade 1, grade 2, grade 3, and now they have added the latest classification, something called as tumor depth of invasion. There are a lot of criteria which is responsible. If you want me to answer that 5 year survival question is, if you do a proper surgery of 1 centimeter clearance and clear neck node and proper neck nodal clearance, then we might expect a 5 year survival, but we can't assure. That's what the current scenario is, sir. Quality of life and the pre-flap is a different scenario, because in Western literature, in Western, I mean, in USA, when I went there, I saw a 90 years old lady, sorry, 86 years old lady who has got a alveolar carcinoma, and they are going to reconstruct that lady with an microscopy flap. In India, it is not possible. So that is still debatable, sir.
Ashok sir,
Yeah.
sir, what was Dr. Jatin P. Shah's answer to your question on that conference? We are curious to know.
Yes, sir. So, what is your insight, sir? What is Shah's perspective on this, sir?
He got a bit shocked that I asked him. I suddenly got up in my usual way and asked him. I told him, I asked him the other way. I said, why hasn't your survival improved in the last 20 years, immaterial of whatever type of surgery you're doing? The number of patients who were dying 20 years back is similar to, I think this conference was somewhere in 2010. He disagreed. He said, no, more patients are living now, but the quality of life is better. But he did not give me objectively saying, for example, 40% of my patients lived for 5 years, but now 45 or 50 are living. He did not give me that at all. He just kind of evaded that question. He just said the quality of life has improved. And as Ilangumaran said, he says it's debatable. But he said it's on the upward trend. That was his answer.
And
Yes,
also,
sir.
yes, sir. It depends
Can
upon
we move on to the next question?
Yes, yes.
I
Yes,
just want to welcome on board our senior most mentors of mentors, Professor Muthushekhar. I just saw him. I admitted him. So welcome
sir.
on board, sir. Is our
Good evening, sir.
one of our senior most teachers and mentors.
Good evening, sir.
Hello, sir. The next question would be, what is the recent advances in the treatment modalities of oral cancer?
Treatment modalities in says there is not much of difference in the surgical modalities, starting from your types of maxillectomies and your mandibulectomies, or the neck dissection and the flap remains the same. And coming to the starter hypothesis, field carcinogenesis and clearing the whole area of carcinogenesis after post surgery with sterilizing the whole area of the cancer patient. The post-surgery sterilization is done by radiotherapy. But what is the recent trend which adds little bit more to the existing treatment is your monoclonal antibodies, which is called as cetuximab. This is comes around 3 injection, which comes around 1.2 lakhs. They say here we have to understand the cancer biology and the hallmarks of cancer. As I told you, when a person has got cancer, the cancer cells grows enormously. Or even during surgery, would have seen during neck dissection, the field will be very, very clear. But when you go near the tumor site, the bleeding will be more. The reason is because of vascularization. When there is a tumor, the tumor area will be hypoxic. When that area becomes hypoxic, there will be numerous amount of blood vessels which will be forming near the tumor, and that is the source of energy, food for the tumor to grow. So when you try to control the tumor growth in and around that area with surgery, radiotherapy, chemotherapy, you have to add something called as cetuximab, which is a monoclonal antibody. What this is very important. It acts on the vascular system or the vascular endothelial growth factor. It inhibits the growth factor of the vascular endothelial factor, so that the tumor getting food reduces. In that way, you can control the tumor growth, and also when the tumor growth is controlled, and it can be very well killed with the radiotherapy. So, but it is still debatable because there are numerous studies which goes on stating that a patient with post surgery goes into radiation. During radiation, the most common chemotherapeutic agents they add is your cisplatin. The cisplatin has been added to enhance the features of radiotherapy, because when you give radiotherapy constantly, what will happen? The tissue will go for shrinkage. There will be devoid of blood supply. It will be avascular. When the tissue becomes avascular, what is the point in keep on eating it with radiation? So what they do is they give cisplatin. When they give cisplatin, the vasculature improves, and also the mode of taking the radiation into the tissues increases. So by doing that, the cancer has been cured, or it has been sterilized completely. On top of it, there are two studies which compare radiotherapy with cisplatin and radiotherapy with cetuximab. They say that there is no difference with cetuximab, but the take-home message in this current scenario, the latest modality is your cetuximab. You should never forget that, because it is very expensive. But if you add, there are few literature which supports the action of cetuximab, which acts on the vascular endothelial factor, which will inhibit the growth spot to the tumor.
If I may add, I think it's also an epidermal growth factor receptor inhibitor, cetuximab. So what, my understanding of cetuximab when I studied my work was, it basically has a role on contact inhibition. Yes. So how cancer cells growth is different from a normal cell is, we theorize that when cells grow, when it comes in contact with another cell, the growth is stopped. It knows that I've reached my limit and it will not grow more. But the cancer cell will continue to grow even if it comes in contact with another cell. Yes. So that's the concept of contact inhibition. So this growth is being promoted by something called as an epidermal growth factor, which is on the wall of these cells. So cetuximab is supposed to go and inhibit this particular growth factor, thereby preventing further growth. And this theory is what works very well for breast carcinogenesis. And that's why breast cancer is handled very well, because the main mechanism by which breast cancer cells populate is with this epidermal growth factor. So that is like the most common reason for breast cancer growth. And that's why we have high success rate when treating breast cancers, and it works well there. But it doesn't work very well in our oral cancer because there are other factors also playing a role in our oral cancer. So I just thought I'll add on it.
Definitely,
Sure.
ma'am.
Thank you
Very
for your
nice
inputs,
point.
Dr. Madhu. Can we move on to
Madhu,
the next question?
for
Yeah.
you know,
Yes.
Yes, sir. Yes, sir. Please.
is it worthwhile trying EGFR inhibitors for
So,
say
exactly,
patient with
that's
terminal malignancy? You know, if, for example,
no, sir.
inoperable.
No, sir. No, sir. No, sir.
So-
It's more of a supportive therapy. That is it. It wouldn't guarantee you a cure. It would only be a supportive therapy, especially on a terminal stage. It'll only go on a palliative stage. Now, again, as Dr. Kumaran said, it's pretty expensive. Is it worth it? So all this becomes a question when you're actually giving the options for treatment to the patient. But it really doesn't help in treating a patient at a terminal stage.
So it is more like a neurobion for a medical oncologist.
Okay, sir.
Moving on to the next question. What is brachytherapy? What is the indications and contraindications of brachytherapy?
Okay. So a VIP comes to me. Hello, am I audible, Karthik?
Very much.
Okay. See the concept of brachytherapy. Before going into it, you should know the concept of treating a oral cancer. If a patient comes to you with a oral cancer, and the first line of treatment is always surgery followed by radiotherapy. So there is no doubt about it. I'm repeating it again. A person comes to you with oral cancer. The first line of treatment is surgery followed by radiotherapy if it is very well resectable. The point is, sometimes, for example, a patient comes to you or an actress come to you with a carcinoma of lip. Then how we are going to treat the patient? For example, if a patient comes to you with a lip cancer, what we do is we'll do the wedge type lip excision and we'll try to approximate. By doing so, what will happen? The size of the orbicularis oris will come down. So you will end up in microstomia. Then the quality of life is being terribly affected. What is the point if after post surgery if the patient can't able to open the mouth? So it is totally very deliberating, isn't it? So in those situations, then you can treat something, think of alternative therapy, and which is very good. And this brachytherapy is useful for T1 and T2 tumors, and it is best for T1 tumor. And you know what the brachytherapy they do here? For example, a person got a lower lip cancer. There are small tubes when you're under local anesthesia or general anesthesia. It is mostly done by the radiation oncologist. Sometimes they used to call us for help if there is a bleeding or something. Otherwise, they will manage by themselves. What will do? They through the cancerous tissue, they will insert these tubes, and these tubes will be collected to the radiation machine, and the radiation will be given to that site very specifically, and pinpoint they will give the radiation dose only to that region. By doing so, you are preserving the lip tissue, and in that way the patient will have a very good quality of life. But on contradictory, what you should be aware of giving a brachytherapy is you are given to the tumors of buccal mucosa, lip, and floor of the mouth. All these tumors are very close to the one bone called as your mandible. When you have heavy radiation dose close to the mandible, there will be breach of the periosteum of the mandible, or it may be too much of radiation dose. Then at times there are higher chances of patient getting a osteoradionecrosis at that point. So it is always a double-edged knife. You should handle it with proper care, or a minimal radiation dose, or otherwise you should be aware of osteoradionecrosis in the site very close to the mandible. That's it.
Thank you.
Madhu, madam, you want to add anything to this, ma'am?
No,
Madhu,
no,
Karthik?
sorry. No, Doctor.
Thank you. Can we move on to the next question?
Yes.
Yes.
So neck dissection for Karthik, please go ahead.
Yeah. What is your stand on neck dissection for N0 tumors involving tongue, floor of the mouth, buccal mucosa, or maxilla?
Okay. So you should not have any doubt on this neck dissection because it has become very simplified. And there are only 3 types of neck dissections we have. Let me go from bottom to top. So your selective neck dissection is your selective neck dissection, which means selectively you are removing the nodes, isn't it? Which means you are removing only the fibrofatty tissues or only the nodes in that area. By doing that, so the quality of life or the patient does not have any morbidity associated with the problem. So when the patient has got N0 tumors, the option for you is selective neck dissection. But if the patient has got N plus node, then you should try of doing modified radical neck dissection, which means there will be a tumor, there will be a node which is very close to the your spinal accessory nerve at level 2A or level 2B, or for example, level 2A is most commonly involved node. In that scenario, if the node is very close to the spinal accessory nerve, then you might have to think of something called as perineural spread. If the perineural spread is there, the spread will be very, very quick, and no matter, the perineural spread will take you directly into the brain metastasis. So you should be very, very cautious about perineural invasion. Perineural invasion is if a tumor is close to the nerve fibers will take the cancerous cells along its path. That is called as perineural invasion. So you should be very, very aggressive in treating tumors near the nerve. If it is so, then go for modified radical neck dissection, removing the neck nodes along with the spinal accessory nerve. By doing so, what will happen? The patient have a problem in lifting his shoulders. Okay, that is a problem associated with your spinal accessory nerve. If the node is stuck to your internal jugular vein as well as your spinal accessory nerve, then you have to be really, really, really radical in doing this neck dissection, which is called as radical neck dissection, which means you are leaving only the carotid artery in the neck, and you are removing all the three non-lymphatic structures, which is your sternocleidomastoid, spinal accessory nerve, and your internal jugular vein. Removing all three structures is called as MRND. Selectively removing one or two structure, it may be IJV or IJV along with your spinal accessory nerve. It's your MRND and its type. Removing no lymphatics is the selective neck dissection, or in olden days it's called as supraumbilical neck dissection. But the latest terminology is selective neck dissection, which means if you do a selective neck dissection, you have to say you have removed level 1 to 3 or level 1 to 4. That is the understanding of telling selective neck dissection. So coming to the neck dissection for tumors involving tongue, because tongue is highly, if you see the tongue is made up of a different anatomy. If you take a buccal mucosa or masseter muscle, it's a different concept in anatomy. But if you take tongue, you have your intrinsic fibers, extrinsic muscle fibers. If you cut through the cross section of the tongue, you can see the tongue muscles which are very, very longitudinal, which which helps the tongue cancer to spread fast. And there is a concept that if you go back to your first year anatomy, and the most common question what they ask is lymphatics of tongue. If you take the tongue, the tip of the tongue will drain into the submental. If you take the sides of the tongue, it will go to the submandibular. If you take the posterior aspect of the tongue, which will drain into your level 2 nodes. If you take your level 2A nodes, if you take the center aspect of the tongue, the dorsum of the tongue, it will again go to level 2A or level 2B. The problem is sometimes they will skip all level 1, level 2, level 3, and it will go directly into the level 4, which has been confirmed by a study called as Bayer study. So always when you do a tongue tumor, for all oral cavity cancer, it is safe enough to remove level 1, 2, 3. When it comes to tongue cancer, you should always remove 4. That is because of the Bayer concept. In his study, he found that in tongue cancer, apart from the lymphatic drainage of the tongue, level 1A for the tip or 2B for the lateral aspect, and for the central under the base of the tongue, it comes to the level 2B, level 2A. He has seen documented patients where there are neck nodes in level 4. So for an M0 patient of tongue, you should remove from level 1 to 4. And even tongue and the floor of the mouth, these are the aggressive type of oral cancers. You should always remove level 1 to 4. If it is node positive N1 or N2, then you have to consider doing MRND. If the node is struck to any of this non-lymphatic structure, then consider doing MRND. When you compare with tongue and floor mouth, buccal mucosa and maxilla is totally different. They drain predominantly into the level 1 to 3. Tongue and floor mouth, level 1 to 4. Buccal mucosa maxilla, level 1 to 3. Is that okay?
Yes. Dr. Madhu, would you like to add anything on that?
No, sir. I think
I'd like to add one question to it, though.
Yeah.
Please, sir. Please, sir.
We used to have this confusing terminology called functional neck dissection when we were training in the UK.
Yes, sir.
Where would that fit in? Is it selective?
It's a fantastic question because people they confuse with MRND and SND. See,
I'm good in asking questions for
very, thank you very much. So when you take MRND, as I told you, apart from the lymphatics, if you remove only the lymphatics, patient will be comfortable. At the max, what will happen? They will have a scar in the neck and maybe hollowing in the submental region because you are removing the submandibular node. Apart from that, patient will not have any problem when you do a selective neck dissection. So when you do a selective neck dissection, that's why they call it as functional neck dissection. You are not removing any non-lymphatic structure. For example, if you remove your spinal axillary nerve, they can't able to lift their shoulders. They will have problem in shoulder dysfunction. If they remove sternocleidomastoid, what will happen? The turning of neck or all those things become problematic. If you remove IJV, then the patient may have edema in draining the one side of the face. These are the problem associated when you remove non-lymphatic structures. So when you prevent doing when you do an SND, you are doing a functional neck dissection. The neck will do it all its function. The spinal axillary nerve will do all the function. The sternocleidomastoid muscle will function, and your IJV will keep on draining all your deoxygenated blood into the heart. So by doing so, it is functional neck dissection. That terminology is being changed into selective neck dissection.
Yes, I came
Essentially,
across
two types.
different terminology.
Yeah, what is that?
It's called a super selective neck dissection. Is there any role on this in day-to-day practice?
Yeah.
Super selective neck dissection.
So when I was in Kidwai, when some of the people they ask, I say SND is the younger brother, and he is the middle fellow, and this is the elder one. If you want something called a super selective, then you have to bring it down this. And
Embryo.
no, super selective in sense
Okay.
you are not
Okay.
going selective neck dissection or supramoid. From supramoid only we came to the term of selective neck dissection. Okay. So in olden days, they have a concept of removing only the tumors of submandibular node. Now you all very established that when you have a oral cancer, you will remove the neck nodes from level 1 to 3. In those in olden times, they have a concept of removing only submandibular or only submental for oral cancer. So in that situation, you have to bring it as super selective neck though. So it is
Thank you.
younger brother to selective neck dissection, which no more exists. You should not do that.
Sure. Thank
So
you,
it will
Dr.
not be
Ilambar.
complete. Yeah.
I
And
have got
really, I want
one
to add
more.
one more thing, Karthik. There is
Yeah,
something called
sure.
as extended selective neck dissection, which is if you do level 1 to 4 in a tongue cancer, the fourth node, this level 4 becomes positive. Then in that situation, still you can do a functional neck dissection, preserving the spinal accessory nerve, and you can go ahead and clear the level 5, which is called as extended selective neck dissection or extended neck dissection.
Thank
We'll
you.
go to the next question now.
Yeah, sure.
Yeah. Hey, please, Karthi, tell me if I take too much of time.
No. You proceed. I think this is the last question, I guess.
Yeah, thank you.
The
Yeah,
question is bilateral R&D, precautions, complications, and prognosis. When do we do? How do we do? What is the complications expected? And how is the prognosis of such patients?
okay. So bilateral R&D precautions, right? So first of all, you should be very, very clear in taking a cancer surgery for, a cancer patient for surgery. That is most important. So if a surgeon, if you can able to do all the type of surgery, doesn't mean that you have to do it. You have to restrict yourself in certain areas. But still, if a young patient comes to you with a very aggressive tumor, and the best example is the tongue cancer, because we have a clear demarcating line, something called as your midline. If the patient has got cancer on the right side of the tongue, eventually it's not reported to you, to any of our, to us, and eventually from T1 tumor it goes into T4, and from the right side of the tumor it crosses the midline. In that situation, and the patient on one side of the neck has got node fixed to the IJV, where you have to remove the do a radical neck dissection on one side, and he has got N2 A, N3, which means he has got bilateral nodes. In that situation, young patients, you can try, go and do it. The only one precaution here is when you do an R&D on one side, you can remove the internal jugular vein. On the opposite side, when you go and do it, you should try to preserve the internal jugular vein. Otherwise, the patient will have severe edema in the face, and it will be very difficult for them to come out of it. But if you don't have any other choice, still you can do it. But it's always better to choose your patients and get it, because There is one concept in cancer which is still exists. More the nodes, lesser the prognosis. Or you really want to put too much of complication into this patient and you want to decrease his life by doing a surgery, or you wanted to do an other type of morality and you want to increase in that scenario, is the take home message. You have to weigh the pros and plus and minus, and you have to take the decision. If it is surgery, then please proceed with bilateral R&D, because the outcome will be very, very bad. Imagine one side R&D, you're removing all the nerves. Opposite side also, if you're trying to do it, what is this quality of life? It's terribly, it will be bad, isn't it? But still, if it requires, go and do it. Try to preserve the internal jugular vein. So that is it.
Yes, thank you, Dr. Kumar. And with that, we come to the end of session one. Thank you so much for your elaborate answers. And there are few questions in the chat box which we will be asking you at the end of the session.
Thank you. Sure.
I think
Right
we
now,
can
we
ask now, sir, so that we finish with
okay, then
malignancy.
fine. Yeah, there are few questions which has been asked by the participants. One is, what is your take on molecular margins? This is one of the question. The other question is, sir, in which situations we prefer to do a suprahomohyoid neck dissection?
Supraoma, so that's what I told you. Neck
It's already
dissection
answered.
in sense N0 selective neck dissection 1 to 3 for oral cancer, N0 for tongue and floor mouth 1 to 4, and if the node is positive, then do an MRND. That's all.
Your
Coming to what
take
is
on
that
molecular margins?
molecular margin, see, oral cancer per se, when you do it intraoperatively, you need 1 centimeter of margin, three-dimensionally. Whoever surgeon or whatever the surgeon is qualification, imagine the tumor and imagine the tumor in a three-dimensional way. You have to take out the tumor with 1 centimeter margin. But there are situations where we are not sure. Even after taking 1 centimeter of margin, you will get positivity. That's why they say intraoperatively we should use frozen section margins. When you use frozen section margins, you can come out, you can detect the margin involvement. The reason is, when you have a tumor, there is something called as a concept called as in submucosal penetration of the tumor. The tumor will be in the buccal mucosa, but when you try to do and margin at the retromolar region, it will be positive there. The reason is because of the submucosal migration of the tumor. So it is always better to do it with a frozen section. Coming to the molecular margin, I think I don't know what the question is looking for.
Yeah, that is fine. So one of the question is, sir, do the skip metastasis follow level to level, or it directly skips to level 4?
See, no, this Bayers has done a study. He says that in its relevance, because it is not that the cancer is directly sitting on the level 4. He has done R&D or MRND. In that, he has done taken samples from level 4. In that level 4, it has come positive. Because you should know how this functional neck dissection system has evolved. Initially, in olden days, they were all doing radical neck dissection. That's what my teacher used to say. When a general surgeon does a radical neck dissection, no problem. It is a treatment. But when a core specialist does a radical neck dissection, it is wrong. Because you are the core specialist, you should not do a radical neck dissection, giving a morbidity to the patient. Because the general surgeon is trying to increase the life expectancy of the patient. Here, we are giving the life expectancy along with the quality of life. So you have to be very, very crisp and clear in doing the neck dissection.
Thank you. Dr. Madhu, there are a few other questions. Should I ask, or should we keep it for the end?
Jimson, sir?
Yeah, you can continue the questions. You can finish the session. I mean,
yes,
the
sir.
questions for this session and then go to the next
Yes,
one.
sir. One of the question is, sir, why we should remove the sternocleidomastoid and muscle in R&D?
Is it to get access or because the muscle is involved?
So no,
Yes.
it is a concept box. You have to take it in that way. See, this person, Kreil, yes, documented first the radical neck dissection. Once the radical neck dissection has been done, it was been keep on doing it. They were doing it in the olden days in the Western countries. In America, they were doing it. And here comes our Jatin Shah, the hero of this oral cancer. What he does, it's very, very interesting. An Indian going and sitting in America, what is this? He wanted to pursue gastro, but he was pushed into head and neck. So he was there. And in those days, they were for all oral malignancies or all head and neck malignancies. You mean oral cancer, laryngeal cancer, oropharyngeal cancer, whatever the cancer type. The neck dissection is they do radical neck dissection. So what this Jatin Shah that did is 10 years of file he has taken. He has split the patient into oral cancer, laryngeal cancer, and laryngeal types of cancer and oral cancer. And he found that the oral cancer patient metastasis, or he has seen only the neck nodes involving level 1 to 3. That's why he has suggested to do net dissection for oral cancer 1 to 3. If you take a laryngeal cancer, then the nodal pattern is not level 1A and 1B, not your submental submandibular. It is your upper jugular, that is your level 2B, mid digastric, and your level 4. So if you see an head and neck surgeon operating on a laryngeal cancer, he will remove nodes from level 2 to 4. If you see for oral cancer patient, they will remove the nodes from 1 to 3. So here ends the, what is the question, Karthik? What is that? I'm not getting.
No, why should we actually remove it?
Okay, remove it. That's what I told you previously, isn't it? If the node is stuck to the muzzle or it is stuck in the
Is
head
it just
point,
for
because
the axis, or is the muzzle
no,
really
it is
involved?
the nomenclature. For example, if you do a third molar, you can't remove the third molar along with the lingual nerve, isn't it? You have to remove remove the third molar. So if you say R&D, you have to remove the sternocleidomastoid muscle, because that is the defined procedure.
Yes,
It
there
is
are two
being,
questions on chemotherapy. What exactly is the role of chemotherapy in head and neck cancers, and when do we add it as a adjuvant therapy along with the radiotherapy?
the one indication for primary tumor is you're done a surgery, and post surgery you are seeing the biopsy report. In that, the margin is positive. Once the margin is positive, the patient is already went home. So then in that situation, you can add chemotherapy along with the radiotherapy. But the problem is, when the patient is margin positive, then when you add chemotherapy, the survival rate is drastically, it will come down. So if the patient is got margin positive, then you have to go back and redo it. That is the take home message. In that situation, if you can't go back and do the surgery, then the only option left is adding a chemotherapy. And coming to the neck, you are doing a radical neck dissection for an advanced nodal disease, and you are giving the specimen to the pathologist. The pathologist reviewing the specimen, and he says that the cancer is confined to the node itself. Then there is no need of adding chemotherapy. When the cancer is coming out of the node, when there is an extravasation of the cancer into the neck, then you have to add chemotherapy. These are the two main indications of adding chemotherapy. One is the margin positive, and next is the extranodal extension of the tumor.
Yes. What is your idea on role of sentinel node biopsy in neck dissection?
Okay. So to coming back to the question of maxilla, what I told you, when in maxilla, the hard palate cancer, you are removing it, and I told you it will take another 15 to 20 minutes to do an neck dissection, isn't it? One simple neck crease incision of around 2 centimeter, you can do an selective neck dissection. But what is the sentinel node biopsy? They say is you have to put a dye on the cancerous part, and with a gamma probe, you have to find the first echelon of nodes. For example, a patient with tip of the tongue cancer is reporting to us, and what is the echelon? What is the lymphatic drainage of the tip of the tongue? It will go to the submental node, and you are putting the dye, and you are using a gamma knife, gamma probe, and you have detected the node in the submental. So removing only the submental node is called as what is that question?
Sentinel node biopsy.
Sentinel node. So the when you remove the first echelon of the node is your sentinel node. But the point is, we are not sure whether the nodal spread will remain only in submental or it will progress to submandibular. The problem is, if it progresses to submandibular, what will happen? If it will become N0 to N plus. When it falls in the criteria of N plus, the survival will decrease. So if it is my relative, I'll definitely do an selective neck dissection. And this selective node, this sentinel node biopsy is a debatable one, and it is not coming to the clinical picture. They are doing a lot of trials. So far, whatever trials they have done, there are patients reported with neck positivity, that is the neck nodal recurrence. And when they have neck nodal recurrence, we know what is the prognosis of the patient.
Thank you, Dr. Kumar. And last question, how to diagnose occult metastasis in head and neck cancer?
You can also tell us about Jatin Shah's landmark paper. He published something on occult metastasis, right? In some
Yes,
level.
sir. He says that when you take when a patient walks into your clinic with a oral cancer, the chances of he getting nodal metastasis lies around somewhere between 30 to 40%. So that is what occult metastasis is. That's why he is emphasizing on doing a selective neck dissection level, clearing level 1, 2, 3 for a patient with oral cancer. So the incidence is 30 to 40%. So by doing so, the survival will be increased.
One last question. I think one of my PGs posted, Ramya Harika. She's asking, should post-operative radiotherapy and chemotherapy depend on WPOI? And she says worst pattern of invasion.
Yes, sir. Sir, when you take up the histopathology of a tumor, there are many things are there to quantify the treatment post-operatively. In that, the pattern is, I mean, one of the criteria is the worst pattern of invasion. This is what the pathologists are reporting. So the best idea of practicing oncology is after surgery, document everything with the histopathology report, sit in the tumor board along with your radiation oncologist and with your medical oncologist and the radiation oncologist. Then you can discuss the pros and cons, and then you can choose an best adjunct along with the surgery.
Thank you very much.
Thank you.
Thank you, Dr. Kumaran.
Excellent presentation.
Thank you, Dr. Ilan Kumaran, and thank you, Dr. Karthik, for moderating that session. Dr. Ilan Kumaran, I think you were wonderful in answering all the questions. It was really useful to all of us. You may take leave if you want to, or you can wait for attending the rest of the sessions.
Thank you, ma'am. I
request Dr. Ilan Kumaran to stay back till the end of the session.
Okay, sir. Sure, sir. Thank you, sir. Thank you, sir.
So
he may rejoin end of the session.
Sure, sir. Okay.
Yes.
Thank you.
So the next mentor
you have space.
Yes, sir. Yes, sir.
Okay. Jimson sir, shall I move on?
Yeah.
So the next session is the miscellaneous session. The miscellaneous session is basically where we have put up all the spillover questions from the past 10 sessions. So there were a few questions which we were not able to take because of time or certain reasons. So all those questions have been put together and you have 2 mentors to answer those questions. The first part of the session will be mentored by Dr. Thomas Zakaria. Dr. Thomas Zakaria obtained his BDS degree from College of Dental Surgery, Manipal, and went on to complete his MDS in Oral and Maxillofacial Surgery from A.B. Shetty Memorial Institute of Dental Sciences, Mangalore in 2005. He worked as an assistant professor in the Department of Max-Fax at Manipal College of Dental Sciences till 2008, before proceeding for a 1-year surgical fellowship program at Meenakshi Cleft and Craniofacial Center, Meenakshi Ammal Dental College and Hospital, where he continues to work since 2009 as a faculty. He is currently Associate Professor in Meenakshi Ammal Dental College. Sir has various publications, presentations, and guest lectures to his credit, and he has also contributed chapters to Textbook of Oral Medicine and Radiology by Ongol and Praveen. He won Best Delegate Paper Award at Tamil Nadu State AMSI Conference in Yekat. He has an ongoing research grant project from Meenakshi Academy of Higher Education and Research on condyle and disc position changes after orthodontic surgery. He also has a patent on a modified lingual flap retractor for mandibular third molar surgery and sagittal split ramus osteotomy. His fields of interest include orthodontic surgery, TMJ surgery, secondary deformity correction, reconstructive surgery, and rhinoplasty. We welcome you on board, Dr. Thomas Zakaria, sir.
Thank you very much. It's indeed an honor to be a part of a panel for the AMSI Meet Your Mentor series. I thank Reena Madam and Jimson Sir for giving me the opportunity to appear as a faculty in this session. And I hope, and I've been given a very challenging task, that is, I've been given basically all the leftover questions from all the previous sessions. And I had to refer a lot of text and articles to answer all the questions to the best of my ability. So if I fall short, my sincere apologies. Basically it's a jack of all arts job that I've been given instead of one particular specialty. So I'll do my best to answer all questions.
Dr. Karthik, you may start with your moderation.
Yeah, please. Dr. Thomas, can you start sharing your screen or slide, your PPT, please?
Can you see the session? Can you see the?
Yes, we could able to see it.
Okay.
Yeah, can I start with the first question?
Please.
Yes, the first question is dredging method for cyst West tumors or cyst and tumors. What is dredging method, the technique? How is it different from marsupialization?
Basically, dredging is a term that is derived from maritime technology, where you use one of these ships that you can see to clear the bed of a harbor or river by scooping out the mud, weeds and rubbish with a dredge. Okay, so that same technique was adapted in oral surgery, where it was fundamentally developed as an alternative conservative treatment of ameloblastoma that accelerates new bone formation. After deflation or marsupialization and enucleation, repeated dredging surgery is performed to accelerate new bone formation by removing the scar tissue from the bony cavity. And this was first introduced by Kawamura et al. In 1991. I have given the reference there. So your first step is basically a de-roofing or marsupialization, where you surgically excise a portion of the cyst wall, overlying bone and mucoperiosteum in order to release the intracystic pressure and decompress it and allow formation of allow formation of a clear bony outline of the lesion. The second step after 3 months, is the enucleation of the lesion. Once you get a clear bony outline, you completely remove the tumor wall supplemented by peripheral osteectomy if required, and the bony cavity is kept open, it's kept patent. And after 3 months, you do this dredging to remove any scar tissue that could fill up the bony cavity and prevent bone formation. So basically, you induce bone formation by removing scar tissue. And this dredging is carried out at every 2 to 3 months interval with the general aim of boosting new bone formation. And at every session, every dredging or treatment session, you take tissue that you have dredged out and see if there is any residual tumor tissue. So this is basically the protocol. As you can see, the first visit is a basic de-roofing or marsupialization, decompression. After 3 months, enucleation. Then every 3 months, you can do about 4 or 5 dredging sessions every 3 months. And each session, you take tissue for analysis to ensure that there is no more pathological tissue till you are totally tumor-free. By the 5th or 6th session, the studies have found it's tumor-free generally. So if you ask me, it's mainly done for unicystic, for basically tumors. It's principally similar to a Waldron's technique of cysts, for the treatment of large cysts, where enucleation is staged after an initial marsupialization, only suitable for unicystic ameloblastoma. I put that quote unquote because a lot of people might disagree with what treatment would you do for unicystic ameloblastoma, but this is what the literature I have found, and it's also been reported for OKC and a glandular odontogenic cyst. This indication is suitable for young children and young adults as a conservative treatment for locally aggressive lesions with high recurrent potential, because it obviates resections and other radical therapy. But the disadvantage is it needs a continuous follow-up, and it's got a lengthy treatment phase. And you need to take repeated histopathological samples to ensure that you have completely eliminated the tumor and prevent any recurrence. So that is basically what this technique is about. These are the references I found. This is for this benefit of PGs, they can refer to these articles. There's a lot of these. This technique has been published from Japan, and only couple of articles have been published for cysts. One series for OKC and another as a single case report for a glandular odontogenic cyst. But the others are mainly for cystic amyloblastoma.
Yes. Yeah.
Beautifully explained,
sir.
Dr. Thomas. It just reminds me of our treatment plan for the Adair Combe River. That's what they're trying to do there.
Sir, if Muthusekhar sir is there still, can we have a word with him about this dredging method for ameloblastoma? Ashok sir?
Is the boss there, sir? Are you on board still, sir?
Jimson sir?
Yeah. I think sir is still here. I think I'll try to unmute him.
Muthusekhar sir? Yeah. Meanwhile, we'll move on to the next question.
Sir is unmuted. Sir is unmuted.
Sir is there. Yes, sir.
Yeah.
So welcome.
Yeah, welcome.
Hello, sir.
I just kept silent. I didn't want to interrupt.
Sir, you're always
Sir,
silent.
good
We
evening.
pull you out.
Good evening, sir. Good evening, sir.
Good evening.
It's a pleasure to have you on board, sir.
Okay.
Sir, what is your take on this dredging method for ameloblastoma, sir? Can you give us some insights on that?
I'm not very familiar with it. Sorry.
Yes, sir. Yes, no issues.
I'm not very familiar with it.
So most of the articles on dredging method is from Bangladesh. They say that there is a sequential, as Dr. Thomas said, there is a sequential removal of the base of the tumor to improve or to accentuate or to have the favorable environment for new bone generation.
That is actually
that is
a
one
very
of the
old
alternate
method only.
methods.
No, it's a very old method. What's been, I mean, that day in our
Yes.
talk, George Paul also was telling this.
So this is a spillover question from that session only, sir.
So still that it's being, I mean, I was not very familiar with the dredging. The word dredging was not getting into me, but this method is very, very old. Unicystic ameloblastoma or the small ones, young patients where you don't want to do a very radical thing, you can do it, and it has worked with me. I've done, I mean, Dr. Madhu knows about it. She has seen some patients. We are still following it up, and they're all doing fine. But we have to keep a watch. That is very, very important. At least once in 6 months, we have to see and keep a watch.
Yes, sir.
It's
Thank you
a new
so much.
terminology for an old technique, sir, probably.
Yeah, that's what.
Yes, thank you so much for your
Old
kind
wine.
words, sir.
Old, yes, sir. New bottle,
The next
old
question
wine.
to Dr. Thomas. To next question is intralesional injections for central giant cell lesions, the theory and mechanism of action.
Okay, I will just give a small introduction to the rationale for using intralesional corticosteroid therapy for central giant cell tumors. Actually, that the lesion is supposed to be a misnomer. It's not called central giant cell tumors. They are quite aggressive, locally destructive osteolytic lesions, and they are benign tumors of osteoclastic origin, and they are not unique to the jaws, and neither are they odontogenic. They are non-odontogenic. And these giant cells have osteoclast receptors, and thus they represent either osteoclast precursors or are themselves osteoclasts. And histologically, you'll find a lot of multinucleated giant cells, and with throughout the mass, and they have these giant cells excavate bone, respond to calcitonin, and they bind osteoclast specific monoclonal antibody, indicating that they are indeed osteoclasts. So the rationale for giving steroid therapy into this the lesion is a steroid basically is a immunosuppressant. It will inhibit osteoclast formation and its activity, resulting in rapid resolution, promoting bone regeneration and recovery of normal function. Steroids have an anti-inflammatory, immunosuppressor, anti-transcriptional action on inflammatory cells. They permit greater osteogenic activity in the bone cells at the site of infiltration, leading to the formation of osteophytes, thus explaining the osteogenic induction in central giant cell tumors. And steroids, they will also inhibit the extracellular production of lysosomal proteases, which mediate osteoclastic bone resorption. And steroids have an apoptotic action on osteoclast cells and inhibit the transcription factors for the giant cell or osteoclastic cellular proliferation. And there are some protocols that have been published in literature for administration of steroids. The most commonly used one is triamcinolone. It's given at 10 milligrams per mg. So actually it's wrong. It's 10 milligrams per ml, sorry. You mix it with bupivacaine, 0.5%, and 1:200,000 adrenaline. And you inject 1 ml per every cc of the radiolucency. And you can follow either a weekly or a bi-weekly injection. And most publications I've seen, they inject up to 6 weeks. So I've put the references here where the PGs can refer to these publications where they've given this protocol. So that is basically the rationale of using steroid injections for central giant cell tumors.
Yes, thank you. Can we move on to the next question? Yes. The next question is, when do we decide to use a chemical cauterization for OKC, and when do we choose to resect in OKC?
Yeah, see, this question is I found it a little ambiguous because they're totally two extremes of things. One is a very, conservative therapy, and the other one is very radical. So I will try to, I found this question a little confusing, but still I will try to make sense of it by giving the indications for each of these treatments for OKC. So you see, the general approach for treating OKC is enucleation and curettage, or some would say a peripheral ostectomy. That's why I put curettage / or peripheral ostectomy. When do you resect for OKCs? See, when there have been multiple recurrences, 2 or more recurrences after your so-called conservative therapy of enucleation and curettage. Second, in case of large multilocal OKCs in which enucleation and curettage would obviously end up with you would end up with a near continuity loss, so you might as well resect it. You might not have enough basal bone. It may end up with pathological fracture, so you might as well resect it. It obviates conservative therapy. When you have it's totally eroded. You have very little. The inferior rim of mandible is very less. Okay, so the mechanism for recurrences have been suggested as there are remnants of dental lamina within the jaws not associated with the original OKC being responsible for a new cyst formation. Number 2 is an incomplete removal or the persistence of the original cyst because of a thin friable lining, or there could have been cortical perforation and with adherence to the adjacent soft tissue. And last is the remaining any remnant rests of cell rests of dental lamina and satellite cysts or daughter cysts after enucleation. And there have been some strategies that have been advocated to minimize recurrence. One is a wide axis enucleation and curettage for all OKCs with the excision of the overlying keratinized ridge mucosa for those of primordial origin. And an important thing is the OKC should be removed as a single untorn, unshredded unit. They will have some notchings and outpouchings which make removal more difficult, but they also increase the risk of shredding of the lining and this friability. And this actually will promote the recurrence. So you have to try to remove it in one single lining instead of it coming out piecemeal. Try not to remove it piecemeal. It increases the risk of recurrence. And third is a good wide axis which would demand a complete lateral cortication so that the entire cyst can be directly visualized during its removal and can be removed in one unit. See, blind curettage in a bony pocket will invite recurrences. Coming to where you use carnoid solution, chemical cauterization, you see, carnoid solution has a very predictable and time-dependent depth mechanism of action, and provided it is not without injuring the neurovascular structures, provided it is not in contact with the inferior alveolar nerve for more than 2 minutes. A 5-minute application will penetrate bone to a depth of over 1.5 millimeters. And because most residual cysts, residual cells and daughter cysts from locally recurrent lesions are adjacent to the main lesion, it's likely that fixation of vital bone need to be only extended for about 2 to 3 millimeters beyond the enucleated lesion. So one of the ways in which they have tried, when you're in case you're doing chemical cauterization to minimize along with peripheral ostectomy, to minimize resection, if you're using peripheral ostectomy, the problem with this this curettage, the problem with the curettage is it's the immeasurability of the amount of resection. You don't know whether you removed all the tumor. It's a very blind procedure. It's an inaccurate technique as opposed to resection if you're doing a peripheral ostectomy or curettage. So you can mark out the after enucleation or the curettage, you can mark out the residual cystic bony cavity with methylene blue to ensure that the entire cyst cavity has there's no remnant lining there beyond the simple enucleation. But again, the problem with this technique is you don't know after you remove the dye also how much of bone removal is have you actually done. So this is basically as best I've tried to answer this question, where you would do the best way of using if you're doing a conservative therapy with peripheral ostectomy or curettage, how to minimize recurrence as opposed to a radical therapy like, and of course the indication for a radical therapy like resection. And of course, OKC is still controversial. Literature will confuse you more. A lot of people will say different things. So this is what I found from a consensus from 2 or 3 textbooks and articles.
Can I just add on my own view? It's not my own view. I mean, I worked for 10 years with Dr. Vinod Narayanan, who's with us no more. There is a different school of thought which does not support carnoid solution. I mean, remember, carnoid is potentially carcinogenic. It's your ethanol, chloroform, glacial acetic acid, and all of them are carcinogens. Till date, FDA has not approved carnoid for medical use.
That's correct.
Number one. Number two, the paper published by Stollinger or whoever in the days of the old was a single arm study where he took, say, I can't remember, maybe 15, 20 cases and predicted excellent results. It was not, he did not have a control or a positive control where he said, 10 cases with carnoid, 10 without carnoid, 10 something else, So I have my own reservations about using carnoid, primarily because it is potentially carcinogenic, is not FDA approved, and the paper published was just because it was by Stollinger. I mean, we have to use it with caution. I know a lot of units use it, but there has been studies which have said that using or not using carnoid has had the same result. I think what is important is a sound surgical technique rather than relying on carnoid, because I want PGs to actually think about it before they use it. One, it will burn the skin, and you need to really protect the entire oral mucosa with wet gauze, and you'll have to take gauze pellets like peanut gauze and very, very gently count the number, put a clock and do it very, very meticulously. So it's just my personal view.
If the PGs who are attending today had attended the session, sir, I think Muthushekar sir and George Paul sir had also mentioned the same and very clearly explained as to how to use carnoids. Measure the gauze, put it in, and then make sure all the gauze that you counted is out.
I'm very pleased. I said I did the same thing. I mean, this is the first time I'm logging in. So
yeah, so sir has already said that, sir. Thank you, sir.
Yeah. on behalf of myself, I would like to add one thing on this note on Cornoy solution. There is a controversy existing between Cornoys and modified Cornoys, which is basically without the chloroform. In our unit, we did an animal study on both Cornoys and modified Cornoys with different time intervals, which is 5 minutes, 8 minutes, and 10 minutes, exposure of a viable bone on the rat. It showed the same amount of depth of penetration on both Cornoys and modified Cornoys. So if that is of use, even modified Cornoys without chloroform can also have has also a role without compromising the carcinogenic tab on it.
I mean, just as on a lighter note, whiskey is whiskey, whether it is single malt or a blend, it is harmful.
So it depends on the person who consume it, I guess.
Yes, what controversy there also actually.
Yes. Yeah, we'll move on to the next question on the session. The next question is peripheral versus central sensitization.
Okay, this is see, peripheral sensitization is a decrease in threshold or an increase in responsiveness and sometimes the spontaneous activity of peripheral ends or of the nociceptors or the pain receptors. It occurs after tissue damage and inflammation and arises due to the action of inflammatory chemicals released at the affected site by both sensory nerve and inflammatory cells. And these mediators of inflammation like bradykinin, histamine, prostaglandins, nerve growth factor, they will increase the excitability of nociceptors by lowering the threshold at which these ion channels open and result in longer opening times, finally resulting in a prolonged depolarization and an enhanced response. So basically, as you can see in this figure, in a non-inflamed tissue, the same A delta and C fibers would only cause mild pain, it would not sensitize the nerves. The patient would only experience mild pain. But in this scenario when there is tissue damage, as the definition says, if there is tissue damage, then the same mediators will cause an increased response or increased sensitization to pain for the same amount of stimulus. So that is peripheral sensitization. It's very obvious when you have tissue, a peripheral tissue injury. Your response to an inflamed site is much more than the site if it were not injured or inflamed. As opposed to that, central sensitization is it basically manifests in tactile allodynia. Allodynia is a pain due to stimulus that does not provoke pain, and secondary hyperalgesia. Hyperalgesia is an increased pain from a stimulus that usually provokes pain. In a tissue that has tissue that is not affected by any harmful condition, in normal tissue. So basically the problem lies in the CNS. This pain is result as a consequence of changes within the CNS that lead to alterations in how the sensory input is interpreted, rather than affecting any of the peripheral receptors, peripheral nociceptors. And the definition by the International Association of Study of Pain describes central sensitization as an increased responsiveness of nociceptive neurons in the central nervous system to their normal or subthreshold afferent input. So basically the problem lies in the CNS, and usually it is seen in conditions like fibromyalgia. So you have an increased awareness of the noxious events, increased central sensitization of the pain. There is no tissue damage in the peripheries. It's a problem with the processing of the pain in the central nervous system. I hope I have explained this as best as I could.
Yes. Can we move on to the next question?
Okay.
Yes. What is interpositional jump grafting in maxillofacial surgery?
This term is an interesting term. This jump grafting, you get this term from these jumper cables. If your car is not starting, you basically, if the battery is down, you take a cable from another car battery, and you put those cables are called jumper cables. Okay, so I'll explain how this works in the field of nerve grafting. It is classically, it's been reported for this facial hypoglossal nerve anastomosis. See, the classical facial hypoglossal nerve anastomosis involves complete transection of the hypoglossal nerve. You can see the hypoglossal nerve over here as it goes deep to the posterior belly of the digastric and between the facial and the lingual arteries. So the classic technique when you want to anastomose the facial nerve, suppose the facial nerve is cut for whatever reason, you make the same. It can be during primary parotid surgery, okay, it can be a secondary surgery. The exposure is the same, just like as you do for a parotidectomy. So you completely transect the hypoglossal nerve and you you anastomose it to the facial nerve. The problem with this technique, the classic facial hypoglossal nerve anastomosis, is the ipsilateral tongue will get paralyzed. Okay, you will lose motor supply to the tongue on the same side. So the jump grafting technique is basically where the nerve is not completely transected, as you can see in these pictures here. You basically take a single cable from the hypoglossal nerve, or you can take a double cable and then anastomose it to the distal branches of the facial nerve. It's a type of cable grafting, and this is the classic technique. This is a classic technique you can see in the first picture where the nerve is completely transected. In this jump grafting technique, you do not completely transect the hypoglossal nerve, but basically you make an oblique incision on the hypoglossal nerve so that the hypoglossal nerve function is intact. At the same time, you graft the hypoglossal nerve to the distal branches of the facial nerve you can either use the great auricular nerve, or you can use the cervical cutaneous nerves C2, C3, or the sural nerve. But the graft length should be at least 5 to 7 centimeters. So the advantage is that it preserves tongue function because you are not completely transecting the hypoglossal nerve. So that is what this jump grafting technique is. You can use a single cable or a double cable. So this is I've put in some references, and this is basically the answer to this technique, this question.
Thank you, Dr. Thomas. Shall we move on to the next question? Yeah. What is McComb's nasal dissection?
Yeah. This is basically, it was proposed by Harry McComb. He's an Australian cleft surgeon in 1975, where he advocated the extensive dissection and mobilization of the lower lateral cartilages in a primary unilateral cleft lip repair. Because as you know, in a primary unilateral cleft lip, the lower lateral cartilages are distorted, and it will not sit in the correct position when you do the closure. So you basically access the lower lateral cartilages through the same cheiloplasty incisions through the vestibular incision or mucosal incision. So you do a medial dissection between the cartilage and the overlying skin and mucosa in a subdermal or submucosal plane. And basically what this will do is it will reduce the buckling effect of the lateral crust of the lower lateral cartilages, and it will sit in a more natural position. So you can introduce these scissors either laterally from the lateral aspect of the buccal sulcus under the skin and above the lower lateral cartilages, and you do a very extensive dissection right from the nasal rim up to the nasion. And to the opposite side of the nasal tip also. And then you again do the same dissection from the medial aspect of the cleft, again freeing the skin from the columella crura, the medial crus, and to the nasal tip. So this is basically the picture that tells you how distorted these lower lateral cartilages are in a cleft patient. It's very broad. The axis of the nostril is very horizontal. There's a posterior lateral alar displacement, minimal nasolabial groove. Septum is distorted. The domes are separated. So this is the dissection. You basically dissect it between the skin in a subdermal, submucosal plane. Of course, you go through it from the mucosal incision, dissect the medial aspect of this cartilage and also the lateral aspect of the cartilage. And the important thing is to use these stent sutures, use these bolster dressings, and you bolster it from above and below. You nicely prop it up so that the new shape is maintained, because once you have freed the cartilage from the overlying adhesions of the skin, you have to fix it in the new position. So you use these bolster dressings from the nasal vestibule and on the skin, and you close it up, suture everything, and you put these bolster dressings. So this is how you put the bolster dressings in the vestibule as well as on the skin. So this is basically your Macom's nasal dissection, where you address the nasal cartilages in a primary chelioplasty.
Thank you, Dr. Thomas. That was well explained. Shall we go to the next question? Yes. How to plan the transport segment and vector for neocondyle distraction?
Yeah, this is basically, it's the literature says there is no technique as such. This is one of the first publications, one of the better papers that came out, where they did this neocondyle distraction for in about, I think, 13 cases by Schwartz et al. They propose using an L osteotomy, as you know, that is the standard osteotomy for neocondyle distraction. And they mentioned that this vertical limb of the L should be parallel to the vector, so that it will take the distracted segment into the glenoid fossa. So keeping the vertical limb parallel to the vector of distraction, to the placement, and of course, you know, the vector of distraction is determined by the placement of the distractor. So this is how they will place the distractor parallel to this vertical osteotomy. And then, of course, in the glenoid fossa, if you're doing a primary gap arthroplasty, either you can line it with dermal fat graft or temporalis flap. And this is how they will try to aim it into the glenoid fossa. It is, of course, this paper says that they have hit the bullseye, they got it bang on into the glenoid fossa. But if you ask me, I would say a better option would be to use an STL model. This is another paper where they have done the same neocondyle distraction using an STL model. You can actually plan your osteotomy, and you can even distract it so that it reaches the glenoid fossa, and you can even adjust the occlusion. As you know, as you distract it, the ipsilateral posterior occlusion there'll be an open bite. I mean, it'll, of course, the vertical ramal height will increase. So you can factor in all these things while you are doing an STL model planning. So if you ask me, these are the two techniques that I have seen in literature where you can probably get the best outcomes and the best way to control the vector in neocondyle distraction.
Thank you, Dr. Thomas. With that, we'll move on to the next question, which is, do we get new bone formation in the hard palate when we perform palatoplasty for a patient aged between 14 to 16?
This was quite a difficult all the questions I found difficult. It was more like I feel like I'm the one giving the viva here. Like an assignment for me. So this is one of the tougher questions that, difficult to answer. The questions are very easy, but the answers are difficult. So you see, there has been a review of literature where they have studied these papers where they have claimed bone regeneration after palatoplasty. And this paper came out in 2019, where they have done literature review, and only 4 papers qualified for this meta-analysis. Only 4 papers where they have claimed that there is bone formation after palatoplasty, and they have basically proposed certain theories where how this bone forms after palatoplasty. They say that if the morphological normal bone is formed if the mucoperiosteal flaps from the hard palate and the vomer are placed close to each other, are in contact with each other. They suggest that the osteoblasts in this mucoperiosteum play an important role in bone regeneration. They also suggest a phenomena of endoperiosteal bone formation. That is, after palatoplasty, the bone defect in the hard palate, as you know, is sandwiched between the nasal layer and the mucosal layer. Okay, and between these two flaps, there'll be narrow space where there'll be a clot, and that clot will get there'll be osteoblastic activity in the clot, and it'll begin to ossify, something like how you get ankylosis. So these are all, it's just it is just a suggestion or a theory by the authors. So there have only been 4 papers that have actually qualified, they have claimed new bone formation after bone regeneration after palatoplasties. Most of these papers, 3 of them are from China, okay, and the sample size are all around. Some are 30, 29, 52, and one is 9. They have done in both bilateral cleft lip and palate and unilateral cleft lip and palate. All of them, 3 papers evaluated the bone formation with a CT, and the age of the patients was all around say 7 to 9 years. That is. And the width of the palate, only in one paper they mentioned that the width of the palate ranged from 4 to 6 millimeters. So this is this review paper meta-analysis, it basically concludes that it is too early to give a judgment whether there is actually a phenomenon of bone formation after palatoplasty, because only 4 studies have been done, and they need larger studies with larger sample sizes. So this is how best I could I could do justice to this question, a very difficult question.
Yes. The next question is there any difference between the composition of Tumescent solution for hair transplant and facelift?
Yes, I have, if you do a facelift or a cervicofacial rhytidectomy, all of them basically, the Tumescent solutions will use, they have lignocaine. These are basically 2 compositions for facelifts. One uses 2% lignocaine, the other one 1%. Epinephrine, again 1 to 2 ml of 1:1000 concentration. Again, ringer lactate, and both of them basically diluted to about 500 ml. So finally, the dilution there's only 0.3% of lignocaine with about 1:250,000 epinephrine. So the question was, is there a difference in the Tumescent solution in facelifts and hair transplant? For hair transplant, it's basically the same, nothing very different, except that this is they again use 0.1% lignocaine, and it's more diluted adrenaline. Maybe not 1:1000, but maybe 1:250,000 to 500,000, and they use sodium bicarbonate also here, and of course the quantity is much less. So this is what I could. This is basically. I hope this answers the question in the difference of the solutions between for hair transplant and facelifts.
Just to clarify, 1 in 1,000 we use only in cardiac arrest or anaphylaxis, and that too we give only 0.1 to 0.2 cc. So I'm just wondering whether it's a printing error. I mean, why would anyone inject 1 in 1,000 2 ml? The patient will die.
No, but you see, they're diluting it in 500 ml. So finally, when you dilute that in 500 ml, finally the actual dilution is 1:250,000.
I get it. Absolutely right. Thank you very much. I did not understand that. Thank you. Thank you.
Yes. Moving on to the next question. Uses of rigid external distractor. What are the uses of rigid external distractor in maxillofacial surgery?
Okay, see this is your basically a rigid external distractor, also known as the RED. This is the design by this basically the design by Biomet Lawrence. It's a bone. This is a bone-borne distractor. As you know, when you distract, it can be the tooth-borne or bone-borne. So here, it's of course there you can see these plates fixed to the bone. This is the same distractor. If you see the look at the distractor, basically this kind of distraction can be used not only for a LIFO1 distraction. If you make your osteotomy at the LIFO1 level, you can also use it for a LIFO2 and a LIFO3 osteotomy and distraction. So it's a very versatile distractor in which you can get you can get distraction in the many levels. It's a multi-vector distractor, and while distracting, you can alter the pitch. You can alter the pitch by moving these rods, and you can change the vector during distraction. That's the versatility of this RED distractor. This is an RED2 distractor by Martin, where this is a tooth-borne distractor. This is how the here it's not fixed to the bone, but rather to the dentate segment here, a tooth-borne distractor. Now, just to give a comparison with, I will only restrict this answer to the mid-face distraction because RED is mainly to do with the mid-face. I will just compare REDs with intraoral distractors. So these are your intraoral distractors for where anterior maxillary osteotomy and anterior maxillary distraction is now done using intraoral distractor. This is a Martin distractor. This is again a Synthes distractor where a LIFO1 distraction can be done using a intraoral distractor. So the uses, if you ask me, as the question suggested, what are the uses for RED? These are the clinical applications. Maxillary, your cleft maxillary hypoplasia secondary to cleft lip and palate deformity, what you call cleft maxillary hypoplasia, craniofacial syndrome, syndromic and non-syndromic, where you get mid-face hypoplasia, and treatment of obstructive sleep apnea also. Because you can distract at a LIFO2 and LIFO3 level, it's very good for these craniofacial syndromes. The advantage of RED over intraoral distractor is, like I told you earlier, it allows distraction in more than one vector and one plane. You can change the vector during distraction. You can distract at a LIFO1, 2, and LIFO3 levels. Again, depending upon the design of the distractor. Those pictures I've showed you, some are designed for only LIFO1, whereas some are for LIFO2 and 3, and allows a larger magnitude of distraction. That's very important. Disadvantage is, of course, the patient has to wear that halo device, cumbersome extraoral device. Patient compliance is a big factor that goes against this distractor. You get this pin tract infection, cutaneous infection, and the hygiene and the hygiene maintenance is very important. You have to maintain a very you have to keep cleaning the hair and the pin tracts, and it has a less precise vector movement because it is extraoral. The vector control is less precise. Over this, the intraoral distractors, they have better patient compliance, and because it's directly adapted to bone, intraoral, and there's the reduced distance between the callus and the activating arm, you get more precise vector control. And of course, easy wound management. You don't have any problem associated with the extraoral distractors. Disadvantage is you need a second surgery, and the main problem with this is once placed, you cannot change the primary vector. It is fixed as with the way you have fixed the distractor. You cannot change it. That you can change the vector during distraction with the REDs. So this is basically, I hope I have explained this, the uses and advantages, disadvantages of the RED and its, the other distraction used in mid-phase, that is the intraoral distractors.
Definitely. Thank you, Dr. Thomas, for your excellent, elaborate and evidence-based answers for all kind of questions. With that, we come to the end of the session 2. Jimson, sir.
The questions are after Ashok's also finishes, sir. Dr. Karthik?
Yes, Dr. Madhu.
So the end of, after Ashok sir finishes, we will take the questions of the miscellaneous session.
Yeah,
so
sure,
forget all the questions they want to ask. That'll be
no,
good.
it's on the chat box. It's on the chat box, sir.
It's
So
documented, sir.
Thank you very much. Thank you very much, Dr. Karthik.
Thank you, Dr. Thomas.
Thank you, Dr.
It was a wonderful session. As Dr. Karthik mentioned, it was very elaborate, and thanks a lot. We welcome the mentor for our next session, Professor Dr. Ashok Ramadurai, Professor in the Department of OMFS, Thai Mugabage Dental College, Chennai. Sir completed his BDS from Annamalai University in 1995 and then went to UK to complete his FDS RCS Edinburgh 1998 and FFD RCS Ireland in 2000. Sir has experience of work from UK, Singapore, and India. He was at Savita Dental College for over 10 years. He was awarded the honorary fellowship from Royal College of Physicians and Surgeons, Glasgow in 2016. His main areas of interest are dental surgeries and trauma. And may I add that I'm honored to say that Sir and me shared to be examiners for the MFTS of for Royal College of Surgeons, Glasgow. Welcome you, sir. And over to Dr. Karthik.
Thank you, Dr. Madhu. Welcome, sir.
Yep.
Yes, sir. The first question for this session is, if a patient planned for general anesthesia is tested COVID positive, what is the further protocol of management for elective with emergency procedures?
Okay, this question, I mean, I did not look up the literature. I did not, do internet search. I just wanted a practical answer having friends in England, in Singapore and Savita. I basically ranked 3 surgeons and 2 anesthetists. So the answer I'm going to share is the day-to-day practice, from these 3 centers I've worked. One is Savita, the other one is National Dental Center, Singapore, and a few hospitals in the UK. GA for a COVID positive patient. I think it's very, very standard protocol these days. You certainly have to book an operation theater with a laminar flow. And the average is about 20 to 25 cycles per hour. And my anesthetist says that you have to draw at least 25% of the fresh air. In a country like ours, some theaters do not have laminar flow. Therefore, you need to switch off your air conditioner during your AGS, aerosol generating procedures, intubation, extubation, drilling into bone, cautery. So this can be done like an amendment. And certainly we can use portable HEPA filters for additional support. And HEPA filters is supposed to remove 99.95 to 99.97% of particles whose diameter is 3 micron or less, depending on the type of filter. So essentially, from postgraduate training point of view, you need the answers must be HEPA filtration is mandatory, laminar flow OT with 20 to 25 cycles per hour. Now, the anesthetic, this was the answer given by my previous anesthetist, or even my current anesthetist, Dr. Navneet Krishnan. He says the anesthetic machine, this is day-to-day practice. So he was kind enough to type it for me. So I'm therefore obliged to acknowledge him. I'm very grateful for his help. The PGs can note that the anesthesia machine must be equipped with safety precautions. Closed circuits with soda lime are preferred than open circuits. And he says heat moisture HME filters are applied. And he says the expiratory gas can be actually scavenged into a bucket with sodium hypochlorite solution. It is important to reiterate that intubation and extubation are potentially aerosol generating procedures, because especially during extubation, patient can cough. You all must remember that your coronavirus is primarily, I mean, it's not going to be there in the mouth, it's going to be somewhere in the nasopharynx or in the lung. So if you're going to trigger it and try and bring it out, that's kind of aerosol generating. And certainly minimal staff during these procedures. And in the UK, they have, they actually have red, amber, and green zones. Red zone will have a set of surgeons and nurses, and that's where the operating room is. The amber zone is the recovery area, and then you have the green zone. So they have divided it, and so that's, it's all separate, and there is no transition of nurses. And my anesthetist says rapid sequence intubation, for PGs to note, is preferred whenever possible, and extubation, done in a deeper plane so that the patient doesn't cough. I mean, it's a double-edged sword. If you're going to extubate someone in a deeper plane, there is always the risk of aspirating blood, lung collapse, and things like that. So it's not as easy as I typed out to be. Instruments, standard disinfection with sodium hypochlorite solution, and OTs after the procedure disinfected with the UV light. And he says, treat all patients as COVID positive. As you remember, your RT-PCR, which is the gold standard test today, is only 70% sensitive. So there are 30% chance that the patient is an asymptomatic carrier. Asymptomatic COVID patients, elective surgery. Defer. Definitely wait for some time. ICMR says asymptomatic patients will become non-infective in 3 weeks. Symptomatic patients, if they recover well, in about 4 weeks. So when someone's COVID positive, self-isolate at home prior to surgery for 2 weeks at least. And then maybe you want to test them, and within 48 hours of the report, you certainly can post them for surgery. I mean, all anesthetists in the city recommend 2 things: COVID test and CT of your chest, CT chest. So none of the anesthetists are willing to intubate, even for an intravenous sedation to be done in the hospital. Anesthetists are insisting on CT chest. And just to reiterate, avoid aerosol generating procedures. And if your laminar flow is set at 20 to 25 liters per hour, then it takes for the aerosolization to settle, it takes about 15 minutes. So when you're doing 2 cases, they say allow at least half an hour between the procedures, because most hospitals will have one OT, one contaminated OT, exclusive for COVID. I mean, they wouldn't open several theaters. So you need to allow at least half an hour prior to surgery. Emergency surgery, well, if you can't avoid, then wear your appropriate PP, personal protection equipment, and your powered air purifier respirator, PAPR. Negative pressures room, certainly not in this part of the world, but they are available in certain countries like the US and Singapore. Laminar OT, and I said 20 to 25 cycles per hour. And England, UK is divided, as I said, into 3 zones: red, amber, and green. And the surgeon is already scrubbed, waiting. The surgeon and the assistant doctor and the scrub nurse are already in the red zone prior to intubation, and it should be leave prior to extubation. Beg your pardon. They will have to leave the room prior to extubation, and full clean down of the OT after the emergency procedure. And any COVID theater will have multiple cases. So the theater nurse or the nurse in charge or the theater manager will have to schedule at least 30 minutes between cases. And especially in hot and humid climates, the recommendation is you need to change your OT staff. You need to change your scrub nurse every 2 to 3 hours in a COVID setting. So these are the amendments which are likely to be made for COVID. Less number of staff, three zones, maybe 2 teams of staff, and a lot of these staff will probably be given time off for self-isolation or monitoring, for a few days.
Yes, sir. The next question is, Vecuronium versus atracurium in asthmatic patients. When do we choose? What do we choose?
I must say that I found this question very, very amusing. I mean, this coming from a maxillofacial trainee is absolutely pointless. I mean, we should have some knowledge about skeletal muscle relaxant, but I'm very surprised why this candidate wanted to know. I did not know the answer, and the answer is from two different anesthetists I work with. Well, both the anesthetists say that both these drugs are skeletal muscle relaxants used during tracheal intubation and surgery. They say atracurium does release histamine, produces wheeze, and is contraindicated in asthma patients. Why is it contraindicated? Potentially, it can release histamine and the effects of that. And the other anesthetist said vecuronium, pancurium, rocuronium are all aminosteroid muscle relaxant. They have steroid properties and therefore has a distinct advantage over over atracurium. I'm still puzzled why a maxillofacial trainee wanted to know this.
Sir, maybe not every external is as liberal as you, I guess.
This day and age, in an MDS exam, what we have to ask is, what does the candidate do every day for the living, every day of the week? I think it's very, very important to first test the knowledge of everyday affairs like dental, velar surgery, and maybe this can be the gold medal question.
Maybe it is a gold medal question for anesthesia PG, I guess, sir.
Possible.
And the next question for the session is, sir, can you just change the slide?
Sorry, I got it.
Yeah.
This is very, very important from maxillofacial point of view.
What is the significance of EtCO2 in general anesthesia?
This is very relevant, and I think all our trainees must know the significance of your EtCO2 probe and the reading in the monitor. Essentially, what is EtCO2? End-tidal CO2, non-invasive. It's called capnography, which measures the partial pressure of your carbon dioxide. Is expressed as either a percentage or an equivalent value. Any internet or any textbook will tell you this. What does it do? It is a standard of care today in minimal mandatory monitoring along with your ECG. So basically, minimum mandatory monitoring in a theater setup includes your EtCO2, ECG, pulse oximeter, heart rate, and your non-invasive blood NIBP. I mean, if you're doing an orthognathic surgery, you may need an arterial line for invasive blood pressure monitoring, which will give you a clear picture on the map, which is the mean arterial pressure. How does the EtCO2 help? It certainly will help you to diagnose laryngospasm. It's worthwhile for PGs to make a note of this. Disconnection of tubes, which can happen. Some anesthetists are very funny. They don't, put the tube or connect the tube properly, and it's very irritating when you have a bleeder. The anesthetist will want to remove the head rate, contaminate it, So the EtCO2 will actually flag up. It will flag up that there's something wrong, that the tube is disconnected. And if there are any kinks, the EtCO2 is very sensitive for intraoperative monitoring. And if you're going to have spine surgery, or if you're going to do a posterior iliac graft and put your patient in a prone position, your EtCO2 monitor is mandatory. So laryngospasm, disconnection, tube kinks, and to find out whether it is in the correct position, your EtCO2 is going to help. And when you're doing a CPR, hopefully none of us should do it. We shouldn't have the need to do it. It will definitely tell you you can recognize the efficacy of your CPCR. And it's also a sensitive indicator like your blood pressure and heart rate for hypotension and hypovolemia. So decrease in EtCO2 reflects not only respiratory, but also cardiac functions. So much for your EtCO2. I mean, this is a worthwhile asking question.
The next question is, sir, can steroids be given in immunocompromised patients for allergic reactions? If no, what is the management?
I presume that the postgraduate wanted to know for a drug allergy. I mean, we're least bothered by urticaria, bee sting, and mosquito bite, and things like that. Well, the answer from a UK surgeon was steroids can be used no change in protocol required for an immunocompromised patient. I'll tell you why. Well, what are the short-term, problems, perioperative things? You can certainly have fluid hypertension, fluid retention. It can cause GI bleeds, stress ulcers, perforation, psychiatric disturbances, delayed and abnormal wound healing, susceptibility to infection, candidal infection, and decreased glucose tolerance. So these are the bad sides of a steroid. And it's been published that if for your adrenal axis, the HPA axis to be actually suppressed, you need to subject the patient to steroids for at least 4 to 5 days. It's a general feeling that in maxillofacial we use steroids, especially for fractures and orthognathic surgery, for about maybe first 48 hours. So high dose of short course of steroid like dexamethasone 8 milligram 8 hourly, 8 milligram BD has no long-term sequelae. Surgeons also believe there is absolutely no requirement to taper, which means you can have the first dose of your DEXA during the osteotomy, second one at night, next day. I usually give it 8 milligram 8 hourly. And then after 48 hours, you can abruptly stop it. This is what a lot of surgeons recommend. It's got absolutely no long-term sequelae in maxillofacial surgery because it's very, very short course. I hope that answers the question. So the answer is no change in protocol required. It can be used. And we obviously I didn't know what allergy meant, but certainly in a drug allergy, 200 milligrams or 100 milligrams of IV or IM hydrocortisone is the drug of choice because it's rapid onset of action. And in severe forms of allergy, you can give methylpred, 6 hourly 125 milligrams. And you can also use dexamethasone. So in any acute crisis, the drug of choice is always hydrocortisone. Even in an anaphylaxis, asthma, whatever, the life-saving thing is your hydrocort because of it's a short acting, but a very, very rapid onset, especially when you give it intravenous. This is quite important from exam point of view.
Yes, sir. The next question is, how will we differentiate between vasovagal syncope, hypovolemic shock, and hyperventilation on a dental chair?
I think the MDS candidate who asked was a bit greedy. The first part of the question is very sensible. So how do you differentiate whether it is a simple faint vasovagal or hypoglycemia? Hyperventilation is very distinct, like myself, some people are hyper. But I've answered all three together. I really don't know why he had to actually combine these three. The first two do have some overlap, but they have some distinct features where you can differentiate. Hyperventilation is completely out of the category. It's a differential diagnosis. The patient can collapse, but I don't think there is any similarity. It's a distinct entity. Okay, what is vasovagal or a simple faint? I mean, all of us know blurred vision, lightheadedness, prodromal symptom, sweating. We know all the signs and symptoms. It's important to remember vasovagal usually occurs in the younger age group, in the macho, six-pack gym building guy who tries and holds all his emotions in the dental chair, and you'll. I mean, I used to work in a hospital where we had a lot of prisoners. So I had a guy with a double murder case, and he's actually slaughtered 2 people, and hefty-looking guy, 6 foot. He's like a door, 100 kilos. All he needed is I just had to wave a needle at him, and he fainted. So that's the kind of individuals who will faint. Hypotension, and the answer to the question is hypotension and bradycardia are classical in a vasovagal. So younger age group, all those typically men faint, all those macho men, and the recovery is usually within a few minutes. A little bit about the physiology. This is given beautifully in Davidson's Principle and Practice of Medicine. That's where I learned this. Your vasovagal response is primarily, this is worthwhile for postgraduates to know. The reflex which mediates your vasovagal is called the Bissell-Jarisch reflex, where the afferent and the efferent are all through the vagus, and the receptors are the chemoreceptors in the heart. And the response is typically bradycardia and hypotension and vasodilation. What happens when a patient's in the dental chair? There is always a flight and fight response. There is a little bit of an adrenaline gush because of fear of the unknown, fear of pain. That does happen. How is it different from an athlete who runs? Say an athlete who's runs, he moves. So there is skeletal contraction, there is muscular contraction. So there is return of your venous, blood back into the right side of the heart. Whereas in a dental chair, there is no, it leads to vigorous contraction of an underfilled vessel. There is no return. There is no venous return. There's reduced or no venous return when a patient's sitting down in the dental chair with fear, and after some time there is no return. So it's like our Coronac dental clinics, no returns. All the sensors will go up, the chemical and the ventricular mechanoreceptors and the chemoreceptors are activated. So what does it do? It activates your Bissell-Jarisch reflex, which produces parasympathetic activation, which is the brake of your heart, and sympathetic withdrawal. So basically the throttle, accelerator, you don't give the accelerator, you just apply your brakes. So therefore you end up with bradycardia and hypotension, or both. So classical for a vasovagal, when would you expect a vasovagal? Patients in fear, younger age group. You check, you just do basic monitoring. You check the blood pressure, definitely hypotension. You check the pulse rate, it will be low. The patient will have significant bradycardia. What happens in hypoglycemia? Similar, these are all fairly standard things: sweating, hunger, fatigue, mental confusion. Pins and needles and slurred speech and tingling numbness are characteristic in a hypoglycemia. How do you diagnose it? All of us in this day and age must have an acute check in our dental clinic. Am I audible? I just want to double confirm.
Yes, sir, you're audible.
Yeah, this habit of going on talking. So acute check is very easily, very, very readily available in all practices, hospitals and clinics. So somebody faints, somebody collapses, or if you suspect hypoglycemia, just do a CBG, capillary blood glucose. And it is less than 70 or less than 3.9 millimoles per liter. It is suggestive of hypoglycemia. Tachycardia or normal heart rate. Okay, the patient is usually tachycardic. So if you have a patient, and obviously you would have taken your history, and it would have been marked as diabetes, either insulin dependent, non-insulin dependent, poorly controlled. So usual thing is patient in all the anxiety and hurry walks in with a missed meal. They have not had their breakfast, and you're starting with the procedure and the sugar level drops. The biggest challenge in diabetes is the sugar level can drop very badly. So make sure all your diabetic patients are fed well. And if an event happens, tachycardia is present, that differentiates from your vasovagal. Blood pressure is normal or raised, then that is the differentiating factor between your vasovagal and hypoglycemia. And it's usually elderly. If you have a diabetic man, elderly, it's not going to be a simple faint. It's never vasovagal in an elderly. Is usually hypoglycemia. So what you do, you check the CBG. That's a clear indication. Your tachycardia is an indication. Check the blood pressure. Ask your nurse to do it. And the other patient factors, elderly, missed meal, history of diabetes is definitely a hypoglycemia. Hyperventilation certainly has a gender preference. Hysterical ventilation in an anxious lady, and that's the cohort of patients you get for hyperventilation. Patient actually goes through multiple rapid shallow breathing before he collapses. So that's hyperventilation. Is also associated with your carpopedal spasm. And the patient says, I feel like I can't catch my breath. And there's certainly tachycardia and chest pain. Tachycardia differentiating from your vasovagal, and certainly hyperventilation, hypocalcemia will cause perioral numbness and tingling sensation in certain areas. Well, if you're in the hospital setting, you just need to draw blood and get an emergency blood. Total serum is calcium is less than 2.2 millimoles per liter. So this is more of a clinical diagnosis. You see them hysterically hyperventilate and they go into carpopedal spasm, and this is very, very classical. I mean, it's very, very difficult to. I mean, once you see it, you'll never forget it. There's no way you can even compare it with vasovagal. Vasovagal and hypoglycemia is.
Sorry to intervene. So I think I was in this session. And I remember that they also asked how to differentiate it from seizure, the ventilation and the seizure, hyperventilation and seizure. Now, if the patient has a history of epilepsy and if he's going for an epileptic attack, sometimes he might present similar to a hyperventilation. I think that was a question, sir. If you can throw more light on seizure also, because you've already said two most common reasons for.
You go to googly now. I mean, seizure is very classical, tonic-clonic contractions, and patient loses momentary consciousness and regains within a moment. All you have to do is not to harm them. I mean, hyperventilation, all these things are very clear. Why would anyone confuse from a seizure and hyperventilation?
Because they are yet to read the books probably, sir.
Yeah. I think she can do MCH and appear for the exam next year. He or he.
We'll move to the next question.
Just to show, I mean, examiners like to ask you about Trousseau's sign and Schwartz sign, and that's how a carpopedal spasm appears. If at all you've missed the hyperventilating patient, you can look for these features also, or these are all the confirmative features where the patient goes into carpopedal spasm because of your hypocalcemia, and hyperventilation can cause numbness, perioral numbness.
Yes, sir. The last question for this session is, can we perform minor surgical procedures in asymptomatic COVID positive patients? Is there any change in medications or treatment protocol?
Surgery is surgery, whether it's minor, major, maxillofacial, general surgery. So the principles are the same. Asymptomatic COVID patients, dental-alveolar, assuming you want to remove a wisdom tooth, defer the elective procedure. You want to do a rhinoplasty, sepuloplasty, iliac bone graft, cleft closure, orthognathic, removal of plates. The dry days when we have no cases, we go and take out plates which we put in 20 years back. All that can wait. Defer elective surgery, because one, anesthetists, if you put them, either under sedation or GA, it didn't say specifically GA or LA, I presume it was LA, will want a CT chest, which means subjecting them to hospital. I mean, you need to certainly defer procedure, because even exposure, assuming you have 5 nurses, your nurses can be asymptomatic carriers. The patient will have come to your hospital, meet the receptionist, and then your nurse. So you're on the way. They may have to take private transport. So you're trying and avoiding all the exposure for the patient. So elective surgery, whatever it is, must be deferred. That is the universal answer today. As I said, ICMR says non-infective patients, please wait for 3 weeks. Symptomatic patients, at least 28 days for them to recover. If they are COVID positive, they need to self-isolate. This is a standard protocol for 2 weeks prior to surgery. Then you get a COVID negative test. Even if, I know of a patient who was waiting in OMR Apollo for a few weeks to get an amputation done. The orthopedic surgeon refused to amputate the, I'm not sure if it's the toe or the leg. If they were waiting for COVID, even a condition like that, people wait these days. And as I said, dental-alveolar, try and avoid aerosol generating procedures if you could. Maybe you can use a slow speed micromotor and try and use a little bit of force and maybe a forceps to try and, well, if it's horizontally impacted tooth, you need to cut. Just be sensible about it. There are no proper, guidelines and things are there, but end of the day, it is common sense. And as I said, appropriate aerosolization, it takes about 15 minutes for everything to settle. So you need at least half an hour between the procedures. The asymptomatic thing is no, please wait. That is the answer. Emergency dental-alveolar, you need to follow whatever I said, appropriate PPE, negative pressure room if you can, and laminar flow with 20 cycles and UV light, prior or after the procedure, and the standard wash down procedures. You can have air purifier running in your dental practice. If it needs to be done, it needs to be done. There's no choice. If you can,
please.
okay.
Yes, sir.
Done?
Yes, sir. Thank you so much for your logical and practical answers, sir. That was.
I also omitted. I mean, there were 3 more questions. I didn't find them very relevant. I mean, there were questions like asking for the sake of asking. I mean, the candidate. It was not a question. It was like you can just type the word in the internet and you get answers. That kind of thing. So I refuse to acknowledge that. And I think there was one question which Karthik, you have prepared the answer because I was just lazy.
No issues, sir. It is regarding a drug which is whether it can be used for impaction or not.
Kindly share, sir.
Even I don't have real practical experience on using the drug. So when I went through the literature, actually using the drug has got more mortality rate. So for using such drug for impaction is really a overkill. So I don't want to even include that as a question as well.
Please, my dear upcoming MDS oral surgeons, remember the only thing we have which is ours and only ours is dentoalveolar and orthodontic. The rest of the thing, plastics, trauma is all shared by plastics, ENT. So nobody can do a distoangular impaction in a trismus with septic, conditions, fever, other than an oral surgeon. So don't use all these wonder drugs and kill your patient and take it away. So be careful when you start your practice and do what is predictable. And some tips about appearing for the exam. I have passed a few exams. I think body language is very, very important. The way you sit, please sit erect. And what we were told is to look into the examiner's eye. Don't glare at him. Just look at him into the examiner's eyes with a pleasant smile. Sit erect and put both your palms, on your knees and sit erect. Don't slouch. Don't put your, the elbows on the table. Body language, all that is very important. I mean, if you're appearing for a British exam, the way you walk in itself, 30% decides whether it is a yes or a no. You'll be surprised. I've spoken to so many examiners, being an examiner myself. Body language, the way they dress up, the way they approach, the way they come, decides 30% of the time whether the candidate is worthwhile passing. So please remember the body language. The other common mistake, which soft skills, which the candidate must acquire, is to speak clearly and slowly. Okay. And try not to give all the answers at once. Just wait for the question. Answer to the point. A lot of times examiners will want, practical things. If they ask you about complications of wisdom teeth, start with the common ones, pain, swelling, trismus. Don't start with the rarest of rare, one patient had blindness, the other one had facial palsy. So what I tell my students is, when you are asked about a bird on a neem tree, the obvious answer is either a pigeon or a crow in this part of the world. Don't give answers like a peacock or a penguin. You will certainly fail. Rarest of answers, you will rarely pass. So a lot of examiners who are nice examiners will ask you common things. What you do every day of the week for your living. So answer the common things first, and answer slowly, answer to the point, and don't try and show off with your knowledge. Let the examiner, give the examiner an opportunity to extract the answer. It's a big ego for the examiner sitting on the other side. I've realized, I feel that I'm giving you a clue and I'm trying to get the answer. Let him do his bit of duty. You'll really satisfy his ego. But if I just want on an answer 1 to 10, and if you stop with 1 and 2, I'll be happy to get 3, 4, 5, and then we will progress. If you start giving all 7, then or 7, 8, 9, 10, then the charm of the exam is gone. The examiner loses interest, and you are considered a little bit impertinent, especially in a British exam. So answer to the point. Just to reiterate, body language, how you dress up, Speak clearly, slowly, to the point. Always remember, examiners will ask you common things. What you do, a good examiner will, unless he's a nasty chap who wants to fail you. I mean, we don't get nasty guys these days for the MDS exams. So that is the point. That is my take-home message to you.
Thank you, sir.
Good luck.
Thanks
I'm
a
sure
lot,
all
sir.
of you do very well, and see you in the next AOMSI conference banquet. Look out for me.
Thank you, sir. Thanks a lot, sir.
Yeah. Thanks.
And thank you, Dr. Karthik, for moderating so well all the 3 sessions.
Thank you so much. There are a few questions in the chat. Shall we go ahead with it, or?
I think there are 2 questions, but they weren't very much to this session. So, Jimson,
Okay.
sir?
Yeah.
I think we can just skip it, right?
Yeah.
We can wind up. Jimson, it's midnight for him in Australia, and it's 10:30. I've not had dinner.
So thank you, everyone. And participants, please stay with us to take your questions. The link will be shared now. You'll have 5 minutes to answer the questions. Jimson, sir, shall I share the link?
Yeah, you can, yeah.
The link is shared for everyone. You can answer the questions. You'll have 5 minutes.
How about all of us taking a group photo? It's more like a conference today.
Just a minute. Just few minutes before they
Sure.
finish this. Can I have the link? Can you share the link in my WhatsApp, please?
The one that I just shared, sir?
Yeah.
Yes, sir.
Yeah,
We finished
ma'am.
the
In the meantime, when they are finishing their the questions, Dr. Reena, ma'am, can you make the final comments, please?
Reena ma'am is on
Dr.
mute,
Elevenil
sir.
is also joined.
Yes.
Yeah, good evening, one and all. It's been a fantastic 11 sessions of Ask Your Mentor, an initiative started by the Association of Oral and Maxillofacial Surgeons of India, Tamil Nadu and Pondicherry chapter. Of course, the think tank behind it was Dr. Jimson, our secretary. He's just bursting with ideas in Australia. You guys, you postgraduates are really lucky to have a secretary like him. And with the help of fantastic pillars, I should say, whom we found in Dr. Venel, Dr. Ella Venel, and Dr. Madhulakshmi, who supported Dr. Jimson so wonderfully. So this would not have been possible without the two of you. And the dedication with which, the commitment with which each of the mentors and the moderators have conducted the sessions throughout. I'm sure Dr. Jimson, Dr. Venel, and Dr. Madhulakshmi would agree with me when we say that, you know, the way the preparations were done for the postgraduates. I salute each one of them. And what a way to end. This was a session that's so difficult. You know, the topics were so vast. And Dr. Elankumaran, in his very, you know, no-nonsense way, the way he answered. And, you know, Dr. Thomas Zakaria, I think I'm hearing him for the first time. What passion in the way he answered the question. And of course, Dr. Ashok, you know, in his British way of answering. And the fantastic points that he gave in the end, you know, very useful points because he's met with the Britishers and, you know, he's answered so many exams in the UK. And so out of experience, he has spoken, pearls of wisdom that he has given. And moderators like Dr. Karthik, who've done a fantastic way of moderation, fine way of moderation. I thank each one of you all who have been so instrumental in making this a success. I'm sure Dr. Jimson is not going to sit silent. There is more coming, dear students and faculty members. There's more coming. So thank you so much I feel so blessed to be part of this team. Thank you so much. Good night. Thank you.
Thank you, ma'am.
Good night.
Thank you. Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am, for those kind words. Now it's my turn to thank everybody. Thank you, ma'am, President, for having given the confidence to go ahead and do a program like this from a state office. It's no mean achievement. I think we have done we've got very good feedback from the postgraduates. So at the end of the day, that is what we set out to do, and I think we have achieved it. And like what you said, I would thank Dr. Elevenil and Dr. Madhulakshmi. It is not an easy job. I know how difficult it is
Thank you, sir.
To coordinate with almost 32 people, 32 faculty members, the mentors and the moderators, and to collect the questions from the postgraduates, give it to them, get the PowerPoints, and to get the event running. And it is just not possible without their cooperation. So thank you, Dr. Elevenil and Madhulakshmi. Thank you.
Thank you, sir.
Thanks
Simple
to
word.
you, sir.
Thanks for
Thanks
the
to you,
opportunity.
sir.
sir.
Means a lot. Means a lot for the association.
Sir, I would like to thank everybody with the Tirukural. Selvathul Selvam Sevichelvam Achelvam Selvathul Ellam Talai, which basically means the knowledge which you gained by hearing is the best of all. Hope everybody had a wealthy night today. Thanks to the AOMSA team, and a big salute for your commendable and perennial effort towards the education of postgraduates, sir. Especially Dr. Ilevanil and Dr. Madhu, we could able to hear your kids calling you for dinner, I guess. Dr. Madhu. It's really, really tough for you guys.
Thank you, sir.
You didn't hear my wife shouting, right? She said, if you don't come, I'll put it to the cat.
Sir, I thought it was a routine.
உருட்டுக்கிட்ட சத்தம் கேட்டுச்சு சார்.
Very good. We'll all sign off a photo, sir.
And yes. And I have to thank all the mentors and the moderators and the passion with which they have taken up this task of preparing the questions. Preparing the answers for all the questions, whatever has been asked by the postgrads. So it is really amazing. So thank you all. It was a fantastic series of 11 webinars, almost touching 2 hours every day. So
yes,
and all the recordings are there in YouTube for everybody to see, and the certificates are coming your way in the next few days for the moderators, for the mentors, and the participants, the students.
I think after Money Heist, this is the most successful serial in lockdown period, sir.
Thank you, Reena ma'am. Thank you, Jimson sir.
Thank
you, Ilevanil.
Thank you.
And finally, I think we need to thank the participants who have been with us through all the sessions and who supported and actually motivated us to even do furthermore. Actually, the 11th session was because of the participants and their responses, I guess. Because initially we didn't start off with 11th session. We were planning only for 10 sessions. So the 11th was because of the response that we got from all of you. And we hope that you have really benefited out of this Ask Your Mentor session, because that was the ultimate aim of it. And apart from participants as PGs, I think we've had few senior faculties who've been throughout the session here and there supporting us. Like I've seen Muthshekar sir come to many sessions, Pradeep Christopher sir.
Sir.
Yes, George Paul sir. Yes, as sir said, Sainath Matsasa. So lots of people have been coming to attending the various other sessions too. So that's very supportive. Thanks a lot to everyone. And sir, if they have answered the questions, we can close the.
Yeah, and last but not the least, we have everybody has seen the faces of Dr. Madhulakshmi and Dr. Ilevanil today. At last, they have switched on their camera. So far, we have seen them only behind the scene, only their voice.
Yeah, we are usually using the voice.
Okay. Thank you. And
thank you, sir. Thank you all. Good night, everybody.
Good night.
No, 1 minute. We'll just click picture.
Sure, sir.
Yes, sir.
Yeah. Just for a record.
Thanks, Dr. Ilevanil.
Thank you, Ashok sir. Fantastic, as usual.
Ashok sir, enakku sollala.
Madhu, I thank you from the bottom of my heart. You should have felt it by now.
Sure, sir.
Did you feel any butterfly? No.
Ashok sir and me, Dr. Venil and sir, lunch partners we are. So when we were together in Savita, sharp 12:30, sir will come for lunch. Zik Madhu, shall we have lunch?